Wi-Fi, Dr. Sima, you can use Wi-Fi.
मोबाइल है यार, तो वाईफाई यूज मत कर, एक काम अपना मोबाइल डेटा यूज कर, क्योंकि तू इस पे काम कर रहा है। वाईफाई कनेक्टेड होंगे ना, तो
वो अपने आप ही एंटर कर दें, है ना?
सर वो कंप्लीट कनेक्टेड होंगे ना, तो फ्लैश करेगा।
डॉक्टर विनीता,
हाँ जी सर।
डॉक्टर विकास को क्या होस्ट बनाओगे तभी वो एंटर कर पाएंगे?
नहीं नहीं, अब वो एंटर जूम इन में एंटर कर लिया ना उन्होंने।
नहीं सर वो ऐसे एंटर कर सकते हैं।
शेयर करने को बोलिए उनको, शेयर स्क्रीन।
अच्छा, हेलो डॉक्टर विकास, आर यू लिसनिंग?
Yes sir, good morning sir, I am sharing my screen.
Okay, fine, thank you. Looking nice. Good morning.
Good morning sir.
हाँ हाँ, we can see the screen sir.
अब एक बार स्लाइड देख लो बस एक बार। क्या?
नहीं
Yes sir, we can see. Yes sir.
हाँ, we can. You can all see.
Yes sir.
ठीक है।
Krishna.
Good morning sir, I am sharing my screen.
Krishna.
Okay, okay sir.
Good morning sir.
Krishna.
हाँ जी मैम,
जो YouTube का लिंक है वो आप मुझे भेजो।
हाँ मैं भेज रही हूँ। हाँ मैम भेज रही हूँ आपको।
मुझे भेजना,
मैं
फाइन करूंगी अभी।
भेज रही हूँ। हाँ मैम भेज रही हूँ आपको।
तो आ गया।
राहुल,
ठीक है सर। हाँ
चुप रहो ना यार। हाँ जी मैम। हाँ जी मैम।
ठीक है सर। हाँ
मैं यही हूँ। कृष्णा एक काम करो, एक एक्सटेंशन लेके आओ जल्दी से, एसआर रूम से। कुछ कर तो नहीं रही हो? अच्छा तो हाँ।
Dr. Chabi, can you just share your slide? Just let us see if it is there. Just do sharing of your slide. Yeah, it's done. Okay. All right. Yeah. Okay, you can switch it off now. Yeah.
इंट्रोडक्टरी स्लाइड एक बार शेयर करके देखो।
Chabi, you can remove your slide now.
जो एक वो दिया
एक बार मैं अपना इंट्रोडक्टरी स्लाइड शेयर कर लेती हूँ मैम।
हाँ जी
पार्टिसिपेंट्स आ रहे हैं।
सबको कॉल किया था
19 दिखा है, पार्टिसिपेंट्स 19।
तो वो स्लाइड में क्या अभी शेयर करूँगा क्या? वो जो स्लाइड जो मैं बोलूँगा वो मुझे शेयर करना पड़ेगा क्या?
तो वो तो इंट्रोडक्शन स्लाइड तो बहुत शेयर करेगा ना।
कहाँ पे शेयर करूँ?
तूने बनाई है।
हाँ।
तो वो इसी पे जूम पे शेयर करेगा ना।
तो कैसे शेयर करूँगा?
उसे कृष्णा से पूछ, इस बच्ची का क्या नाम है?
पूछता।
तो शेयर स्क्रीन आ रहा होगा ना, उसमें आपने रखा किया है?
हाँ मेरे पास तो है।
बड़ा प्रॉब्लम होता है सर।
नहीं अरे ये रहा शेयर स्क्रीन, ये रहा शेयर।
हाँ तो आपको अपनी खोल के रखनी पड़ेगी ना दूसरी जगह पे वो स्लाइड। कहाँ से रखी है आपने?
मेल भी नहीं और
व्हाट्सएप पे नहीं सर, आपको नॉर्मल उसमें डाउनलोड
कहाँ है स्लाइड, कहाँ है वो?
हाँ ये रहा
रखिए।
ये
भाई तूने जो बनाई है वो स्लाइड खोल।
हाँ
19 लिखा है, पार्टिसिपेंट्स 19। इंट्रोडक्शन स्लाइड तो बहुत शेयर करेगा। तूने बनाई है तो वो इसी पे शेयर करेगा। ये शेयर हो जाएगी।
अभी कल
हाँ मनोज सर आपका
मनोज
शेयर
अपना
स्क्रीन आ
शेयर
रहा है।
करके देख लो। मनोज
यस मैम,
हाँ ठीक है।
यस मैम
This is
कीर्ति मैम
okay.
आई कैन सी योर स्क्रीन।
सर।
This is shared by Kirti, right?
पार्टिसिपेंट्स हैं कहाँ से कैसे पता चला?
सर वो तो उसी लिस्ट में है, वो पूरा जो
वो नोट करने की ना वहाँ पे।
अच्छा एक्चुअली सर प्रिंट आउट नहीं निकल पाया था क्योंकि वो उसमें था, मैंने इसको कट करवा के गीता जी के साथ
इम्पोर्टेंट में जगह तो इम्पोर्टेंट होती है कहाँ से?
ठीक है सर। तो अभी
ऋषि यू आर गोइंग
बताऊँ
समवेयर?
बिल्कुल
ओके,
Can
और
you
कोई पीछे है
stop
हमारे यहाँ
sharing?
पे? एक एक्सटेंशन मुझे चाहिए ये लगाने की। नॉर्मल कोई भी एक्सटेंशन देता है तो क्या ये लग जाएगी? एक्सटेंशन चाहिए, वहां से कनेक्शन लेना है, एक्सटेंशन वायर। हेलो हेलो, हाँ जी, हाँ गुड मॉर्निंग कौन?
Please keep your phones on mute.
अभी नहीं यार, मैंने वो इंस्टीट्यूट छोड़ दिया है, तो
live
आप
होती
वहाँ
है।
पे डॉक्टर चक्रवर्ती या
Everybody's mic
डॉक्टर
is on. Please
और अभी
Dr. Nadeem,
please mute करो अपना mic.
Dr. Nadeem, please keep all your ये speakers on mute.
We are already live on YouTube. Please, all of you, mute yourself. Krishna, have you checked the YouTube? Is it fine?
Please mute yourselves.
Yeah, please mute yourself. It is quite noisy on the YouTube. We are already live on YouTube.
गुड मॉर्निंग कौन?
Please keep your phones on mute.
क्या हो गया, क्या नहीं होना था? हैप्पी बर्थडे वाले कब मिलेंगे?
Vinita ma'am, it's working, the YouTube. You can broadcast it.
Okay, now I'm sharing the YouTube link and the final poster on the UCMS microbiology group. One second.
मनोज एक बार स्क्रीन शेयर करके देख लो।
हेलो, यस मैम।
तुम अपना स्क्रीन शेयर करके देख लो।
I have shared the YouTube password.
Yes ma'am, yes. I'm
UCMS microbiology group. That can be shared to everybody now.
कहाँ से शेयर करूं? कहाँ से शेयर करूं इसको?
मनोज सर नीचे स्क्रीन शेयर का ऑप्शन दिखाई दे रहा है आपको?
प्रिंसिपल सर को फोन करो इन्हें।
स्क्रीन ना उनकी। हाँ अभी, हाँ मैंने वीडियो ऑफ किया।
We are waiting for Dr. Suchita to reach the director's office. She'll reach in 5 minutes.
Rautela sir has logged in, ma'am. So
Suchita hasn't reached the director's office, so let us just wait.
okay.
मैंने सोचा कि मीटिंग है, हर को कैलेंडर डाल के पूरा क्लीन कर दिया, वो सारे हटा।
Please mute yourself.
उसे हटा हटा के पूरा क्लीन कर दे, फिर कुर्सी सही कर दिया।
Dr. Principal sir is here.
Yes, ma'am.
Okay, so
Ma'am,
we're
he
just
is here.
waiting for. Good morning, sir. We're just waiting for the postgraduate student to go to the director's office.
Urgently.
हेलो, हाँ जी सर, गुड मॉर्निंग।
Internet because coming as internet unstable. I just
ठीक है सर। यस सर। हैं? ऐसे अरे हाँ, अरे नहीं, मैंने तुम्हें बात सुनो, मैंने तुम्हें वैसे ही हेलो किया है, ज्वाइन कर लेना बीच में। अरे मैंने एक ग्रुप बनाया है जिसमें आपको लिंक भेजा हुआ है। हाँ हाँ, आप आ जाओ, आप 10-10:15 बजे आ जाओ, अभी आ जाओ आप, सब लोग हैं। डॉक्टर जैन है हमारे प्रिंसिपल सर, डॉक्टर रोतेला है डायरेक्टर सर, आप भी आ जाओगे तो गीता बोल देगी उसमें। मैंने एक यूसीएमएस का ग्रुप बनाया है आपके उसमें ना, सैटेलाइट वर्कशॉप करके, हाँ उसमें लिंक है।
Please mute your phone. Please keep yourself muted.
सर ने तो सुबह रास्ते में ही बोल दिया था कि डॉक्टर मोना ने भी ज्वाइन करना है।
अरे वो उसने जो ग्रुप बुलाया ना रात को, मैंने उसमें तुम्हारा नाम दे दिया था।
Please, if you are talking personally, please mute your audio version, please. Only the next speaker will speak.
ऐसा आपका हो गया क्या? आपने ज्वाइन कर लिया?
हाँ मैंने ज्वाइन कर लिया। Selective है ये भी।
तो वाईफाई है का? वाईफाई नहीं
लेके आ रहा है यहाँ यहीं पे।
मैं बगल वाले कमरे में कर
मैं आऊँगा ना आऊँ। अच्छा।
Dr. Vinita?
Yes, sir. Yes, sir. Good morning, sir.
It's a sincere request to all to keep yourselves muted.
Sir, I'm waiting for Dr. Suchita to reach the director's office. She's just reaching.
Everybody yourself muted.
वही कनेक्ट करने में लगेगा डिपार्टमेंट वाले।
तो वाईफाई है का?
लेके आ रहा है यहाँ यहीं पे।
मैं बगल वाले कमरे में कर
Charu, mute yourself.
एक मिनट बेटा। मैं आऊँगा ना आऊँ।
Sir, are we all ready, sir? Can we start? Principal, sir, director, sir are here.
Dr. Vinita?
I think we can start. Sir
We
is
can
here.
start now?
Yes, sir. Please, I think you start with the inauguration.
Shall I start, sir?
You can, I think you should start now because Dr. Principal sir is there, Dr. Rotela, director sir is there.
Okay,
So
sir.
I think you can start.
Okay, sir. At the outset, I would just request everybody to please keep your mic on mute. Okay, so good morning, everyone. I, Dr. Binita Kashyap, on behalf of the Department of Microbiology, University College of Medical Sciences, and GTB Hospital, welcome you all to this pre-conference satellite workshop on diagnostic algorithms for co-infection in COVID-19. We are really honored to be conducting this workshop under the aegis of the virtual MicroDcon 12th Annual Conference of Indian Association of Medical Microbiologists, Delhi chapter. I take immense pride to say that University College of Medical Sciences has entered into the 50th year of its inception. And we are really privileged to be conducting the first scientific event under the banner of Golden Jubilee celebrations. At this time of adversity, our respected principal sir, UCMS, Dr. A.K. Jain sir has been extremely supportive, and he has been a constant source of motivation and encouragement to all of us. 1 second, sir, I'll just put in the charge. Sorry. So I would request respected Principal UCMS Dr. A.K. Jain sir to kindly give his opening remarks for the inauguration of this event. Sir.
Dr. Vinita, my video is put off from your end.
Sorry, sir.
From the host side, my video is not coming. The video is stopped from the host side. No, it's already,
Krishna,
I have
Dr.
already
Krishna,
done
please.
it. It says that you can't start your video because host had stopped it.
No, sir, it's video is
Krishna.
on, sir. Hanji, ma'am, it's on, ma'am, sir.
Yes, so please check it.
It's not coming
Okay.
here. It says that you can't start video because the host has, I think, just see the settings. But meanwhile, nevertheless,
The host is, sir, it's
fine.
on. Sir, can you please once again?
Sir, it is
Sir,
enabled.
everyone's
Could you
video
please
is
try
on.
once again?
वॉल्यूम बढ़ा दे।
Anil just said.
Krishna, please allow the video.
Ma'am, it's allowed, ma'am.
Yeah, okay. Sir, could you please check it once
It's the
again?
same. It's the same. It's the same.
Sir, can you zoom in again? Now we can see you, sir. Thank you
Okay.
so much.
Okay.
We can see
Thank
you,
you.
sir.
Sorry for
Thanks.
the...
No, that's okay.
So it was
Thanks,
video, sir.
Professor Vinita, Professor N.P. Singh, and other colleagues of the department, Professor Rotela, learned guest speakers, friends, and the participants in this workshop. First of all, thank you very much for giving me this opportunity to talk to you all on the opening of a workshop on the opening of the workshop Diagnostic Algorithm for Co-infection in COVID-19 under the aegis of Virtual MicroDcon 12th Annual Conference of IAMM Delhi chapter, and particularly making this as the first event of the Golden Jubilee celebration of University College of Medical Sciences. I think when we talk about that, then I think it would be nice that if I speak a few words about UCMS to the learned participants. It's a Constituent College of Delhi University, established in 1971. The first hospital it was attached to was Safdarjung Hospital, and then in 1986 it reached to its final destination with the GTB Hospital. So now this complex is called GTBH complex. We have a very strong faculty of over 240 or 230 plus, and we for last 10 to 15 years constantly ranked in the first top 5 and top 10 institution medical colleges in different by different ranking, including NIRF and including India Today and all other rankings. So we have always performed very well in those rankings. Well, we have the high tradition of publication because the research data of UCMS has always been among the top 3 institutions, the research publications coming out. And so much so that besides the All India Institute of Medical Sciences, Delhi, UCMS is the only institution in from India which is ranked among the top publishers, top scientists, top researchers in the World Stanford ranking. We have UCMS has published many journals, and many journals were launched and they have ended up in becoming an impact factor journal. And but then any medical college is known by the population it caters. So UCMS and GTBH complex is a lifeline to 8 million population of East Delhi and 30 million population of Western UP. And it gives a human services to this huge population. Well, commemoration of Golden Jubilee has always been an event in any institution's life where we rededicate ourselves to the service of the growth of science and service to the mankind. Well, I think the another coincidence and reason is that we are doing this program when the Republic Day celebration are still on. So that gives another opportunity for us to rededicate ourselves to the service of nation. I think medical fraternity as a whole keeps on getting an opportunity to serve the mankind. And it always happens that if you recall the last 10, 15 years, how many situations of the state and national level medical problems which the medical fraternity has handled. And because we have a huge population, India has a huge population, so the natural disease burden is quite high. Number 2, we are not able to provide optimum standard of care to one and all because of a limited resource country. So there is a variation in the health services available throughout the country. And that is why India has always been a place where we see the natural history of disease. But then out of that natural history of disease, the medical fraternity has stood test of time to provide human services to them. And I think COVID-19 is an example, recent example. If you look at the COVID-19, that it just suddenly came in 2000, this November and December 2009, and within 2 to 3 months, it spread globally. The spread was so fast that in about 3 months' time, it has crossed the boundaries of nations, crossed the boundary of continent, and every city, every state, every country, and every globe, every continent was affected by it. I think if we recall when such episode has happened, it was only 100 years ago, that Spanish flu, and we all know that the devastation it produced to the world, and devastation occurred in India. And it took its natural course of about 4 years to reduce, to stop the devastation. But if we compare from that point of view, because we hardly had any experience of handling such a huge pandemic, medical fraternity, they have done a wonderful job, because they have not only treated the new disease, but they have kept an eye on the outcomes of the treatment, and reinvented the treatment and improved the treatment outcomes. So this has given them an opportunity that our death rate has come down, our recovery rate has come down, and now our scientists have developed a vaccine. So the world's the largest adult vaccination program is on. With this all experience, I can say one thing, that this virus, this tiny virus, has made human being humble. Now we have come to realize that the destiny of the world is not decided by the superpowers, by not the guns, by not the missiles. It is the biological particles that decides the destiny of the world, and that decides the world order. And if you look at the history of World War I, World War II, Vietnam War, I think these winning armies, they have lost the war because of many fungal infections, many viral infections, and not because of the superiority of the guns they were having. I think if you look at UCMS and GTBH complex, how this has fared for the COVID, we were declared COVID in June. And at that point of time, in April, May, we didn't have a testing facility. And I must compliment the efforts taken by Department of Microbiology in established a COVID lab, which was ICMR and accredited. And with the help of ICMR, we were able to start COVID testing labs in no time. And not only that, I here communicate to you all that now this, with the help of ICMR and DHR, we have this facility has been upgraded to state level virology lab, and due course of time, advanced virology lab, and due course of time, you will see a lot of changes in that section. So every member of the team deserves congratulations and they need to be complimented for their effort. Since COVID was a nationwide problem and nationwide lockdown, gradually we started, when the disease intensity came down, gradually we started unlocking, and government gave continuous guideline. But then from medical personal point of view, resumption of patient care, resumption of medical education, and reinventing the practice of medicine was a big challenge, is a big challenge, and we are all ready. We are taking that challenge now because we have a huge population, because we have a huge disease burden. Due to COVID, lot other diseases were taken the back seat and they were not treated, but now we have to resume that care also. So in that light, because India always had a high disease burden for infectious disease, this workshop is unique in that direction. And I see this program, sepsis in COVID-19, fungal co-infections in COVID-19, tuberculosis, the mother of all infection with COVID-19, and viral and bacterial co-infections. So these topics are one of the most important topics which are being discussed in this workshop by the experts like Dr. Vikas Dogra, Dr. Gagandeep and Dr. Chavi, Dr. Ashwini Khanna, and Dr. Devashish Dhar. And I'm sure the deliberation by the speakers, because these speakers are well-known names in their field, and the deliberations are going to be useful in providing patient care in various multiple infections and various co-infections during the COVID era. And I'm sure we all will be benefited. I suggest to Professor N.P. Singh and Dr. Vinita that these recordings should be available to the wider circulation, so that the clinicians who have not been able to join and the people who have not been able to join this workshop, they are also benefited. And I think I would appreciate, because this is going to be a good insight to manage these complex issues. So with these words,
on YouTube. Sir, it is live stream on YouTube.
no, it's fine. It's fine. Yeah. Even for later date, if it is available, that would be very
Sure,
fine.
sir. Sure.
And thank you very much indeed for giving me this opportunity to address. And best of luck. Happy learning. Happy learning to the listeners. Thank you.
Thank you so
Thank you,
much,
sir.
sir, for your encouraging words. It surely helps us to keep going. Such a huge COVID-dedicated government tertiary care hospital could not have functioned so smoothly had it not been under the supervision and guidance of the constantly motivated and proactive medical director. I now very humbly welcome our respected medical director, GTB Hospital, Dr. R.S. Rotela, sir, to kindly enlighten us with a keynote address. Sir, please.
Thank you very much. सभी को नमस्कार। आदरणीय प्रधानाचार्य डॉक्टर जैन, डॉक्टर एनपी सिंह विभागाध्यक्ष माइक्रोबायोलॉजी तथा इस कार्यशाला के वक्तागण और सभी प्रतिभागीगण, मुझे आज यूसीएमएस और जीटीबी अस्पताल के माइक्रोबायोलॉजी विभाग द्वारा आयोजित एक डायग्नोस्टिक एल्गोरिथम फॉर को-इन्फेक्शन इन कोविड-19 नामक कार्यशाला के उद्घाटन के अवसर पर दो शब्द बोलते हुए बहुत बड़ी खुशी हो रही है कि आज आप लोगों ने इसके लिए मुझे मौका दिया। वैसे मैं ये कहूँ कि ये कार्यशाला हम इस समय आयोजित कर रहे हैं जबकि पूरी दुनिया के कई देश जो है कोविड-19 के उनके बढ़ते हुए मामलों से जूझ रहे हैं, और दुनिया के कई देशों में तो इस महामारी का दूसरा और तीसरी लहर भी अभी जारी है। मगर हम लोग ये कहें कि हमारे यहाँ पर हमारा देश, हमारे भारतवर्ष का एक सौभाग्य है कि हमारी जो रोज की पॉजिटिविटी जो रेट है वो बहुत घट चुकी है। करीब ये लगाइए कि ये मैं ये कहूँ कि आज के दिन में शायद ये 10,000 के आसपास भी नहीं है पूरे भारतवर्ष में, जो कि कुछ महीनों पहले करीब ये 1 लाख के करीब थी। और ये जो है यह सब जो है ना, ये सब हमारी जो है ये कमी जो पॉजिटिविटी आई है, इसमें हम सभी स्वास्थ्य कर्मियों की मेहनत और सतर्कता और जो अनुभव का कारण है, जो उन्होंने अनुभव प्राप्त करके इसका ट्रीटमेंट किया, इसका इलाज किया और उसके बाद यह परिणाम हमें प्राप्त हुआ है। ये जो कोविड है, इस कोविड महामारी ने दुनिया के कई हमारे देशों में जो ट्रीटमेंट की वो है प्रणाली है, जो स्वास्थ्य सेवा की प्रणाली है, उसको काफी हद तक चेंज कर दिया, काफी हद तक उसमें प्रभाव डाला है। और इसमें इस महामारी के समय हमारे कई डॉक्टर्स, नर्स तथा अन्य स्वास्थ्य सेवा क्षेत्रों में कार्य करने वाले लोग विशेष रूप से इफेक्ट हुए हैं, प्रभावित हुए हैं। और ये सभी स्वास्थ्य कर्मी दिन रात मेहनत करते हुए अपनी रात की नींदों को भी, इन रातों को भी नहीं सोए हैं और रात दिन उन्होंने मेहनत किया है। और कई डॉक्टर्स, नर्सेज और स्वास्थ्य कर्मियों ने इस बीमारी से लड़ते हुए अपनी जान तक भी गंवा दी है। और इन स्वास्थ्य कर्मियों को, डॉक्टर्स को, पैरामेडिकल स्टाफ, नर्सेज को हम नमन करते हैं, जिन्होंने इस लड़ाई के खिलाफ बहादुरी से लड़ते हुए अपनी जान न्यौछावर कर दिया है। हमारी जो चिकित्सा सेना बहुत बहादुरी से थर्मामीटर, स्टेथोस्कोप, वेंटिलेटर तथा अन्य चिकित्सा उपकरण, दवाओं के साथ हर वक्त तत्पर रही है और इस महामारी से लड़ने के लिए हमेशा उन्होंने आगे बढ़ चढ़कर हिस्सा लिया है। और चिकित्सा शोध कार्य में भी, इस क्षेत्र में भी चिकित्सा शोधकर्ताओं ने इस बीमारी के खिलाफ, इसको मारने के लिए दवा खोजने के लिए बहुत ही बाधाओं के बावजूद रात दिन कार्य करते हुए इस रोग के वैक्सीन को बनाने में जो हमें सफलता प्राप्त हुई है, ये भी एक बहुत बड़ा एक कमेंडेबल जॉब है। इसकी भी कोई तारीफ हमें करनी चाहिए। ये ऐसा है कि इस बीमारी को या किसी भी बीमारी को उसका इलाज करने के लिए, प्रभावी इलाज करने के लिए हमें एक डायग्नोस्टिक फैसिलिटी की जरूरत होती है, जिसको कि इस डायग्नोस्टिक फैसिलिटी के लिए, इस बीमारी से लड़ने के लिए हमारे माइक्रोबायोलॉजिस्ट ने बहुत बढ़ चढ़कर और आगे आकर इसका उनका इस समय बखूबी उन्होंने अपना कर्तव्य निभाया है। इस महामारी के समय दुनिया भर के एक माइक्रोबायोलॉजिस्ट एक बहुत प्रशंसा के हकदार हैं और जिन्हें मैं वाकई नमन करता हूं कि इस समय में उन्होंने बहुत अपना, क्या कहते हैं, योगदान दिया है। इस महामारी के समय सभी कोविड योद्धा अपने परिवार से, अपने प्रियजनों से दूर रहते हुए मानवता की निस्वार्थ सेवा में लगे हुए हैं और इस मानवता की सेवा करते हुए अपना बलिदान भी दे रहे हैं, जो कि एक बहुत वह अमूल्य है। और वह आजीवन हम जो है एक मानव समाज जिन्होंने बलिदान दिया है स्वास्थ्य कर्मियों ने, उनके आजीवन आभारी हैं। ये वैसे तो हम ये कहें कि ये कोविड वायरस जब से शुरू हुआ, कोविड इन्फेक्शन, कोविड-19 शुरू हुआ, तब से लेके हमें हर रोज एक नया सिम्टम्स कहें, एक नया एक पाठ पढ़ा रहा है और हम लोग जो है उससे नई सीख लेते हुए रोज अपने चिकित्सा तरीकों में, अपने उसमें बदलाव लाते हुए हमने इस बीमारी से हम लोग लड़े हैं। और हमें जब भी ये चिकित्सा जगत को एक प्रभावी बनाने के लिए उसका बुनियादी ढांचा मजबूत होना बड़ा जरूरी है। और इसके अलावा दुनिया में चिकित्सा अनुसंधान और प्रौद्योगिकी की उन्नति की दिशा में अधिक कार्य करने की आवश्यकता है, जैसा कि मैं समझता हूं। अगर हम ऐसा करने में सफल होते हैं तो यही स्वास्थ्य सेवा कर्मियों के दिए हुए बलिदान के लिए सबसे बड़ी हमारी एक श्रद्धांजलि, सच्ची श्रद्धांजलि होगी। अभी हाल ही में जीटीबी हॉस्पिटल में, यूसीएमएस कैंपस में एक कोविशील्ड वैक्सीन के साथ में स्वास्थ्य कर्मियों के लिए, जो कि फ्रंट क्या कहते हैं हेल्थ केयर वर्कर्स हैं, उनके लिए टीकाकरण का अभियान शुरू किया गया है। इस टीकाकरण का चारों तरफ काफी अच्छी प्रतिक्रिया इस टीकाकरण की मिली है हमें। और मैं ये मानता हूं कि आने वाला जो समय है, हमें लगता है कि कई वर्षों तक हमें इस कोविड बीमारी के साथ ही जीना पड़ेगा। इस बीमारी के खिलाफ मुझे लगता है कि अभी कोई लड़ाई खत्म नहीं हुई है। जैसे कि हम कहें कि वैक्सीन आ गया, इसके लिए इसके खिलाफ लड़ाई खत्म हुई है, ऐसा नहीं है। मेरा मानना ऐसा नहीं है। हमें अभी इस क्षेत्र में बहुत कार्य करना है। और सबसे बड़ी बात यह है कि वैक्सीन लगाने के बावजूद मैं ये बात कहूंगा कि हमें कोविड एयर में हमें मास्क पहनना, सामाजिक दूरी, सोशल डिस्टेंसिंग, हमारे हाथों को स्वच्छ रखना, चाहे सैनिटाइजर से हो चाहे साबुन से हो, ये बहुत जरूरी है। मैं अभी इस समय अपने सभी स्वास्थ्य कर्मियों को बहुत बहुत बधाई देता हूं, जिन्होंने सारी कठिनाइयों और विपरीत परिस्थितियों के बावजूद इस संक्रामक वायरस को करारा जवाब दिया है। मैं इस मौके पर यूनिवर्सिटी कॉलेज मेडिकल साइंसेज को बधाई देना चाहता हूं, जो कि इस साल वो अपनी स्वर्ण जयंती मना रहा है। यूनिवर्सिटी कॉलेज ऑफ मेडिकल साइंसेज की स्थापना, जैसे कि डॉक्टर जैन सर कह चुके हैं, कि सन 1971 में हुई थी, एक कॉन्स्टिट्यूएंट कॉलेज के दिल्ली यूनिवर्सिटी के रूप में। यह संस्थान हमारे विभिन्न चिकित्सा तथा पैरामेडिकल उपाधि को प्रदान करता है। यूसीएमएस की गुणवत्ता के बारे में हमारे प्रिंसिपल डॉक्टर जैन साहब अभी कह चुके हैं। ये हमेशा मैंने जब से देखा है, पिछले 30 सालों से करीब करीब टॉप 10 में ही रहा है, कभी टॉप 5 में भी रहा है। ये सभी आप लोगों के एक महान शिक्षक और उनके योगदान का ही फल है। और वैसे जैसे डॉक्टर जैन कह चुके हैं कि हमारे यहाँ पे जैसे पबमेड जैसे पत्रिकाओं में भी हमारे जो यूसीएमएस की रैंकिंग देता है, करीब करीब ये भी टॉप 10 में ही देता है, और शायद हो सकता है कि 5वें या 7वें नंबर पर ये हमारे रिसर्च का यूसीएमएस की रैंकिंग है। वैसे पिछले कई सालों में हमारे यहाँ के छात्र विभिन्न पाठ्य चर्चा और विभिन्न पाठ्येतर कार्यक्रमों में बहुत उत्कृष्ट प्रदर्शन करते हुए आए हैं, और मुझे पूरी उम्मीद है कि हमारा यूनिवर्सिटी कॉलेज ऑफ मेडिकल साइंसेज इस गौरवशाली परंपरा को बनाए रखेगा और देश में चिकित्सा शिक्षा के क्षेत्र में और चिकित्सा सेवा के क्षेत्र में उत्कृष्टता हासिल करने के लिए हर हमेशा ही तत्पर रहेगा। मैं इन्हीं शब्दों के साथ इस समय विराम देता हूं और इस कार्यशाला को सुचारू रूप से संचालन करने के लिए माइक्रोबायोलॉजी विभाग, यूनिवर्सिटी कॉलेज मेडिकल साइंसेज जीटीबी अस्पताल के सभी फैकल्टी मेंबर्स और सभी विभाग के कर्मचारियों को मैं शुभकामनाएं देता हूं। मुझे इस मौके पर बोलने का अवसर दिया। थैंक यू वेरी मच। ऑल द बेस्ट।
Thank you so much, sir, for always standing with us. Thank you for your motivation and encouragement. It will help us, really help us to cope with this crisis always, sir. Thank you. Now, we have been extremely fortunate to be working under the able leadership of our respected Head of Department, Microbiology, Dr. MP Singh, sir. Sir, can I please...
हाँ नहीं ना, हमें सिर्फ एक आदमी लगाएगा, तब आखिरी में लगवाएंगे।
हम लगवाएंगे, अगर हमारे एक हाथ में एंटी एलर्जिक, एक हाथ से वैक्सीन लगा दे तो हम तैयार।
Sir, can I please request you to introduce the sessions and the participants of this workshop?
Very good morning to all of you. And first of all, I thank Dr. Jain, our principal sir, who has spoken about the he has encouraged us basically, and he has told about the importance of UCMS and GTBH academically and in all other fields. I'm also thankful to Dr. Rotela sir, who has given his precious time, because all the time he is busy for managing the hospital. That is also very important. And I also welcome all the participants. And first of all, I will name the list of participants who are there in this workshop particularly. And these participants, their names are Dr. Jyoti Chaudhary. She is PG. She is from VPCI Delhi. Dr. C. Zobi Akhal Jui, postgraduate from EVLMS Delhi. Dr. Indira Verma. She is a postgraduate from Lady Harding Medical College. Dr. Sneha Day. She is from School of Medicine, that is from Sharda University. Dr. Medical College. Dr. Mukesh Sharma, he is Associate Professor at SGT Delhi. And Dr. Asha Bhasin, she is Senior Resident, and she is Senior Resident from JIPMA. Dr. Lakshmi Jyoti, she is Additional Professor. She is All India Institute, Hyderabad, Telangana. Dr. Suman Tiwari, she is PG Resident. She is from PG Resident from Sharda, Noida. Dr. Khushbu Sareen, who is a resident doctor from BIGMC Pune. Dr. Astha Raj, who is from Delhi. Dr. Divya Shri, she is our postgraduate. Dr. Suchita Gautam, she is again our postgraduate. And Dr. Subhashri, she is working as senior resident in Rajiv Gandhi Super Specialty. So I welcome all the participants. Before introducing my talk, and we have different sessions. That sessions have been told by our principal. And at the outset, I will speak a few words about COVID-19 epidemiology, and after that, we will have the important sessions which are related to sepsis in COVID-19, then fungal co-infections in COVID-19, then TB COVID and TB COVID-19 co-infection, and then viral and bacterial infections in COVID-19. So I will. So now I am starting my slides basically, which is a story from Wuhan to vaccine. This, you all know that this virus particularly, it traveled from Wuhan. It originated from Wuhan, and throughout all the globe it had traveled, and then ultimately it traveled so fast because of globalization. And then we have seen this 1 year, that is every day was a new day. Every means COVID has, every patient of COVID was a unique patient, and means every symptom of COVID was a unique, like there were very interesting symptoms in COVID, like loss of taste, loss of smell. They were so predominant in some of the studies that you could, their sensitivity was almost as similar to as RT-PCR. So now coming to clinical features of, I will not go into larger details of these, but COVID-19 is an acronym that stands for coronavirus disease of 2019, and the name was given by WHO on February 11, 2020 for the disease caused by novel coronavirus SARS-CoV-2. Co is basically corona, and VI is virus, D is disease, and it started in by you all know that the important symptoms of COVID-19, that they are fever, dry cough, shortness of breath, along with the very difficult type, means very unique type of myalgia or feeling of exhaustion, which people have realized, along with some important symptoms of loss of taste and loss of smell. And there are several studies where loss of taste and loss of their average prevalence of loss of smell and loss of taste, it was approximately 41 and 38% respectively. And this was different from other respiratory infections in that usually other respiratory infections which are associated with loss of smell and loss of taste, they are associated with stuffy nose, they are associated with nasal secretions also. But it is supposed that in case of COVID-19, it is the chemosensory damage to olfactory pathway and chemosensory damage to the mucous membrane of oral cavity that has led to the development of this particular symptoms. And again, it has been seen that those who have presented with this symptoms, they recovered very well, or they had a mild COVID infection. The incubation period of COVID-19, you all know that is it is up to 14 days, and the disease ranges from mild to severe and has been classified according to severity as syndromes associated with COVID-19. And these are the syndromes which you all know that. And you have seen that 81% of COVID-19 severity, they have uncomplicated or mild illness. 14% of those develop severe illness requiring oxygen therapy. And it is the 5% who require intensive care unit treatment because of sepsis and because of acute respiratory syndrome, or because of severe pneumonia, or because of septic shock. COVID-19 is a new disease. This you all know. So we all were susceptible for this infection. So thus human do not have any natural immunity against the virus. COVID-19 affect people of all age groups, but you have seen that those who were people of with unique characters like old age, like with comorbidities, like on immunocompromised immunosuppressed therapies, they were more prone for infection. And infection rate, it has though in case of COVID-19, the infection rate was very important actually. You can say that infectivity or transmission of COVID it was so much unique that it spread very soon from Wuhan to all the world, and that is because of its infectivity. And on an average, it infects from 1.5 to 4.5. So one person can infect 1 to 5 people. And R0, this is basic R0, where one person can infect how many a person. If the R0 is more than 1, then the infectivity is supposed to be on higher side. So to reduce the R0 to less than 1, there are several important factors, like reducing the spread of agent through isolation and quarantine. So this word, we have quarantine word, a word has again means used after the Spanish flu pandemic, which occurred 100 years ago. Reducing exposure of susceptible hosts, like social distancing, which is a very which has become new norm now, basically. Reducing environmental survival of agent, that is by hand sanitization, by cleaning surfaces, and by other measures which reduces the which killed the virus on different surfaces actually. And ultimately a very important thing which will help in the reduction of this, that is increased resistance of susceptible hosts through vaccination. COVID-19 spreads by viral load, that you all know. It spreads by two ways: respiratory droplets or indirect spread from surfaces to mouth or nose. And direct spread, you all know, through it is through a droplet nuclei. And in some situation, it may be aerosol generated, that you all know that how aerosols may be responsible for infection, but mostly majority it is droplet infection. So now coming to problem statement of global scenario. So you all know that it started in 2019 of unusual 27 pneumonia cases. So not going into that detail. Then the disease was named on January 9 as COVID-19. Then again, it spread from China to the neighboring 3 countries like Japan, Thailand, and Korea. And disease is spread to more than 20 countries, including India, in January. And in March, disease is spread to 123 countries. And first death in India was reported from Karnataka. So as of now, means on 26 January, there have been approximately 10 crore confirmed cases of COVID-19, including deaths up to the range of 2 million, as reported by WHO. So this is I've already spoken about this. Then problem statement regarding Indian scenario. So again here, confirmed cases, you all know that 1 crore or 1 million, you can say. And deaths, they are ranging up to 1,50,517. Again, the data is of 26 January. And now there is a declining trend that you have seen. And recently on 26 January, like in Delhi, it was only 30,000 tests were done, and only 96 cases were recorded. And the positivity rate, which was the cumulative positivity rate, which was 6.3 or 4, at this point of time, it had come to 0.3%. So that is how now it is declining continuously. And you can read on daily basis, you can see on internet how and in India was one very important country where the active means the cases who were recovering, their percentage was more than the cases who were active, who had active infections. So now response to strategies, you all know that how these things have worked. So Dr. Rotela has also told, our principal sir has also told that you have to control the source of infection. That is both symptomatic and pre-symptomatic, and methods of controlling by testing the suspected and close contact, and by isolating the patients, or by isolating the positive cases. Then to break the chain, direct and indirect spread, which we have already discussed. So there are several measures you can use, use of mask along with hand hygiene and social distancing, and quarantine of the contacts, and home treatment. So all these things were important in breaking the chain of transmission. And thirdly, vaccination will definitely help in the further reduction of this. advisory on COVID-19 has come again. I mean, all the time it was coming from ICMR at different times on regular basis, and which was important for health authorities of state level and India as a whole, how to implement those guidelines. And it was for the first time it was seen that the political will to implement these guidelines were so strong, and the courage of the COVID warriors, as we have become. Actually, we are now known as COVID warriors. So at this point of time, I pay my homage to those COVID warriors who have lost their lives for us, basically. So the algorithm of COVID-19 testing, you all know that it is rapid antigen test, and if it is positive, there is no need of doing RT-PCR. If it is negative, symptomatic, then RT-PCR. If it is asymptomatic, then you have to wait and repeat the test. So these guidelines, then management, you know that I think Dr. Dogra will say a few words on this. So I'm skipping this slide. And the origin of new variants which have come up. There are, like in case of coronavirus, SARS-CoV-2, there have been several hundred variants, but there is importance of approximately 3 important COVID variants which are important. One is UK variant, other is South African variant, and third is Brazilian variant. And UK variant, like on 26 January, it was told by British Prime Minister that likely to be 30% more lethal than the normal strain which was prevalent earlier. And this UK new variant, which is known as SARS-CoV-2, voice of concern, 2020 December, and 01 is the first strain. So it has been reported, now it is 75% of the cases from UK and around around countries. 75, 2/3 of the population has been in fact means they are to be infected by this virus mainly. And this virus is estimated to be more transmissible, as has been said, 40 to 70% infectivity is more. Actually, UK was worried about that their R0 rate was more than 1, and it was approximately 1.5, 1.4 or 1.5, and a shift of 0.4 will make the country like that. Changes, and all these variants like Brazilian variant, like South African variant or UK variant, all of them, they have changes on the spike protein. And you all know that the spike protein is important for the attachment of viruses. That is how it has made the virus more infective for cells which are containing ACE2 receptors. So now coming to vaccines, you all know that there are 4 types of vaccine: virus vaccine, viral vector vaccine, nucleic acid vaccine, protein-based vaccine. And right now, these vaccines, they have gone through different preclinical trial, phase 1 trial, then phase 2 trial, and then phase 3 trials. And after phase 3 trials, authorization have been given. So at this point of time, you all know that there are 4 important vaccines which are being used globally for vaccination. And out of those 4 vaccines, 2 BioNTech vaccine, which is based on messenger RNA, and then this vaccine, particularly Moderna vaccine, it is also based on messenger RNA. And third vaccine, which is AstraZeneca Covishield, where the Indian contribution is also very high. And this is, you all know that this platform was already available. It is a non-replicating adenovirus platform where spike gene has been introduced, and against that antibodies and cell-mediated immunity is being raised. And fourth vaccine, which was given emergency authorization in India, it was inactivated vaccines. While rest of the vaccines like DNA vaccine and other RNA vaccine or subunit vaccines, they are into phase 1 trial, phase 2 trial, and there are few vaccines which you can see here, like inactivated 4 vaccines are in phase 3. Like viral vector vaccine, there are 4 non-replicating viral vector vaccines are available like this. So we all know that in India we are using Covishield and we are using this particularly Covaxin, and Covishield is being manufactured in Serum Institute of India at Pune, and Covaxin is which is an inactivated vaccine, which is made by Bharat Biotech International. And other than this, Cadila is also entering into vaccine production. That Sputnik is the Reddy's lab. They have associated, and Johnson, and there are Biological E Limited Hyderabad. They all are coming. They all have some means connection with other countries, and they are in the different phases of the vaccine production. And after the means, this is the story from Wuhan to vaccine, and you all know that how vaccination drive has taken place in India. It had started on 16 January, I think, and to right now approximately 2.5 million cases have been vaccinated in India. In UK, it was started earlier than India, but at this point of time, there is a quite noise about the supply of vaccine in European countries for Covishield and other vaccines. So I think with this, I end my topic, and I hand the session to Dr. Binita. I think Dr. Binita will hand over for the different sessions, I think.
Yes, sir.
So thank you very much for.
Thank you so much, sir, for enlightening us. You were always standing with us during this COVID crisis, not only on the professional front, but also on the personal front. So we are always grateful to you, sir. So I once again extend a warm welcome to all our delegates, our esteemed panelists and speakers, and also our very dear friends, seniors, and colleagues from UCMS GTBH, as well as from various other institutions. We sincerely hope that you'll enjoy the event as much as we've enjoyed putting this up. And so now I would like to hand over the platform to Dr.
Binita,
Charu
can
Jain,
you,
Assistant
Dr. Binita,
Yes,
are you
sir.
hearing me?
Yes, sir.
Dr.
Yes,
Binita?
sir. Yes, sir.
I think you are seeing Dr. Sherwal is there, Director Rajiv Gandhi Super Specialty, and Dr. Malini Sharif, Head Microbiology Department of VPCI. She is also there. So I think
A very good morning to Dr. Sherwal, sir. We're really honored, sir. Dr. Malini, ma'am. We're really honored to have you here, sir, and ma'am.
Thank you. Thank
Would you like to
so
say something, Dr. Sherwal, sir? Would you like to say a few words?
No, just like I have heard, Dr. NP Singh for giving the overview of, the COVID-19. It was excellent. And, everybody actually has seen the pandemic right from the beginning till the, we can say, beginning of the end till now. And from yesterday, you know that, we are back to normal activity as per Delhi government order. So this workshop is at the right time actually. So as far as COVID is concerned, I hope it is winding up. And but at the same time, we really have to stick to the guideline from time to time to the from the government ICMR, so that we can really end with this peacefully. So that was wonderful, and I look forward to hear from the speakers ahead. I think Dogra is there, so I'm really looking forward to hear his talk. And all the best, Dr. NP Singh and all the team. It's always wonderful to be part of any academic activity and of UCMS, from where I started my academic journey in Delhi actually way back in 1990. Thank you.
With all humility, you always say that you have started your journey from UCMS. So it gives courage to us. So I think
Absolutely, sir. One second, sir. Dr. Sherwal, sir, you have been the pillar of microbiology. हमें जब भी कोई दिक्कत होती है, we feel down during this crisis. हम बगल में राजीव गांधी सुपर स्पेशलिटी की तरफ देख लेते हैं. How you handle the 3 institutions and the way you have been conducting all the things during this crisis, sir. So absolutely hats off to you, sir. Thank you so much, sir, for coming. Dr. Malini, ma'am, would you like to say something?
Just good morning, everybody. And I just would like to thank the organizers that it's a very right time that you have come up with such a good topic. So I just wish you all the best.
Okay, thank you so much, ma'am. So now I think I can hand over the platform to Dr. Charu Jain, Assistant Professor, Microbiology Department, to commence the first session of this event, Sepsis in COVID-19, along with associated diagnostic and prognostic biomarkers. So Dr. Charu, thank you. Thank you all of you.
Good morning, everyone. Good morning, everyone. I am Dr. Charu Jain, Assistant Professor in Department of Microbiology. The current session is Sepsis in COVID-19 and Associated Diagnostic and Prognostic Biomarkers, as Dr. Benita has said. The session moderator is Dr. N.P. Singh, Director Professor and Head in Department of Microbiology. The sir's areas of interest are bacteriology and antimicrobial resistance specifically. He has been an executive member of Delhi chapter and national body IIM. He has been a member of selection board for faculty position and research studies at various prestigious institutes. Sir has more than 60 national and international publication of reputed journals. The session expert speaker is Dr. Vikas Dogra. He is DM Pulmonology, Pulmonary Medicine. He is the head in School of Pulmonology at Rajiv Gandhi Super Speciality Hospital, Tahirpur. His specialty is interstitial lung diseases as well as interventional pulmonology. He is the member of professional societies like European Thoracic Oncology Platform, etc. And he has more than 30 publications in both national and international journals. He has set up the School of Pulmonology at Rajiv Gandhi Super Speciality Hospital, and he is a very active external consultant for Indian Antarctic Expedition since 2015. He has represented India in Asian Forum for Polar Sciences, which was held in Japan. He is a member of COVID-19 cell for the 40th Indian Scientific Expedition to Antarctica. And he's also the nodal officer of COVID-19 at Rajiv Gandhi Super Speciality Hospital. So I would like to hand over the session to Dr. N.P. Singh to take over and please start the session.
So I will not take much time, but I am thankful to Dr. Dogra who energetically he accepted my this thing that you come to our you take one session at our department in the microbiology event of this year, which is known as IMM Microdecon. It's the annual chapter of Delhi IMM, and particularly in this COVID-19. I have seen you working so hard at every level. You were working in ICUs, you were working in, you have established plasma therapy unit there, and you were so much associated. Like I know that Dr. Sherwal will agree with me that it was, you did not go to your home for more than 6 months. So I think I really appreciate that type of I say it is a sacrifice. You will say that this is my passion. So I think now I hand over the mic to Dr. Vikas Dogra, who will be taking this session particularly on sepsis in COVID-19 along with biomarkers. And after that, I may ask some questions because it is very, to ask him questions, it will be not easy for me, I think. So hand over to Dr. Dogra, please.
Good morning, respected teachers, my dear colleagues and students. My heartiest congratulations on Golden Jubilee celebration at QCMS. And I'm honored that you have called me here, sir, for giving a lecture on this occasion. I will start sharing the slides. The topic given to me was actually COVID-19 sepsis with special emphasis on biomarkers. This is actually still a controversial topic if you look into that when the COVID first came to our hospital or in our country, we had very little knowledge. All data we were getting was from media that what kind of virus this is. And we wanted to know that which all people are going into severe disease, which will become mild, which will be in moderate. So we needed some kind of marker that will define that the patient will land up on ventilator or he can be managed at home. But initially we did not have such a comprehensive data about regarding the same. So I will just, along with my this sepsis and emphasis on biomarkers, I will tell you how we use this data in managing our patient at Rajiv Gandhi. Now, this I think SARS-CoV-2 virus structure is known to everyone, and with special emphasis on this S protein, because this is the protein that starts the infection of SARS-CoV-2 and facilitates the entry of SARS-CoV-2 virus into the human cells. And because of its affinity to the ACE2 receptors, that is why SARS-CoV-2 is leading to low respiratory tract infections so much. Now, the early target cells is nasal bronchial epithelial cells and pneumocytes, and S protein binds to ACE2 receptor. But this cleavage of this S protein happens by the host cell itself, which by transmembrane serine protease 2, and this ultimately promotes viral uptake and multiplication inside the host cell. This is actually not a normal virus as compared to previous viral infection we had. It led to dynamic events, which include immune response, inflammatory reactions, and viral replication. And unique to it was the coagulation. So this virus has a vasculopathic nature, and it led to endothelial damage, either directly and also through inflammation. So this vascular involvement was the main thing that was distinguishing this from other viral infections. And poor clinical outcomes were seen with genetic variation, advanced age, comorbidities. In fact, for genetic variation, there is a very interesting article in Nature in which they said that some of the genes which we inherited from our ancestor Neanderthals, that gene was actually responsible for severe outcome in present-day Homo sapiens. So this is an article in Nature. So there were many, these are broadly the things which determine that the patient will have poor clinical outcome. And there was predominantly alveolar damage and ARDS as it was inhaled inside the lung. And because the severe COVID-19, it triggered severe inflammatory response leading to septic shock or multi-organ failure. So this was already covered in the previous slide that most of the infections in SARS-CoV-2 are mild in nature, and the severity of the illness is dependent on the comorbidities, especially cardiovascular, diabetes, cancer, obesity, and lung disease. Now, the problem in like specifying the biomarkers of disease or finding the treatment is because of incomplete data on immunopathogenesis. It is still not complete. We do not know which molecule to target, and that will lead to cure of the patient or treatment of the patient. So, we are using broad-based therapy to suppress like steroids. So what happens actually is that this infects the type 2 pneumocytes of the alveoli, and from there SARS-CoV-2 virus multiplies, and T cell lymphocyte, monocyte, and neutrophils are recruited, and then cytokines are released from macrophages, neutrophils, monocytes, and this ultimately leads to this can turn into severe COVID-19 when this becomes uncontrolled. So the severe COVID-19 is actually a hyperinflammatory response to the virus itself. It's not the virus directly that is affecting the lung, but in fact the host himself is over responding to the virus, and the host own immune cells are killing the damaging the lungs. And also, as we will see in the other further slides also, the COVID-19 virus, the SARS-CoV-2, directly kills T lymphocyte cells. It can impair lymphopoiesis, and it increases lymphocyte apoptosis. So there is chances for lymphopenia, which we all know that is a characteristic feature in COVID-19. There is also endothelial barrier disruptions and dysfunctional alveolar capillary oxygen transmission. There is formation of hyaline membrane. There is formation of pulmonary edema, and there is impaired oxygen gas capacity. And there is bradykinin dependent lung angioedema. The bradykinin is coming up as a important topic in the mechanism by which this COVID-19 is causing injury. So as already told, this is how does a severe COVID-19 infection occurs? It's actually dysregulatory immune response. This production of excessive amounts of cytokines and chemokines, known as cytokine storm, or you can say sort of suicidal tendencies of the human body. And then, or there may be secondary infection, the co-infection that other speakers will talk about. It may be directly viral sepsis or fungal sepsis, bacterial sepsis. Now, cytokine storm, this is the buzzword when this corona came, that patients are dying because of cytokine storm. And it happens when the immune cells are not that effective. They are not killing the virus, but the virus itself inducing a lot of this cytokines, chemokines inside the lungs, and this and in fact the blood circulation, and this can lead to damage to lungs and multiple organs of the human body. So leads to multi-organ failure. Now, further studies have shown that it is actually the bradykinin that is responsible for causing this pathogenic effect of COVID-19. And this was done by at Oak Ridge National Lab Biosciences Division. There's a lot of use of supercomputers nowadays for assessing the spread of COVID-19 virus, how it spreads in different conditions, and what are the genes that are more like overexpressed in case of severe COVID-19. And they found that bradykinin was a key factor. And right now trials are going on because we have a disease called hereditary angioedema, which is a bradykinin pathology. So we have drugs for that. So drugs against hereditary angioedema are being tried in this COVID-19 also because of this knowledge of bradykinin. Now, nowadays, when we talk about microbe and host interaction, we are using the term damage response framework. So as you can see this parabola, what this shows you is that this damage can be because of the defect in the host immune system if the patient is on the left side of the parabola, or it can be due to the overexpression of the cytokines or overactive immune response to the pathogen as on the right side of the parabola. So both factors can lead to the decompensatory disease. Now, sepsis has been, as we know, is defined as acute life-threatening organ dysfunction caused by dysregulated host response to suspected or proven infection. Now, this is a definition which has been given. Earlier, it was said that SIRS, systemic inflammatory response syndrome, plus a source of infection is termed as sepsis. But this was very non-specific, and SIRS generally did not mean sepsis. So this definition was changed to this, and actually it tries to say that it arises when the body's response to an infection injures its own tissues and organs. So as in any of the sepsis pathophysiology, you know, there are tall like receptors that are eventually leading to formation of various cytokines, the interferon alpha, IL-1, IL-6, TNF. Same thing is happening here. They have infected macrophages, T lymphocyte, B lymphocyte, neutrophils, all are involved in recruitment and apoptosis of infected cells, and they can lead to. And in fact, a correlation between sepsis due to COVID-19 and macrophage activation syndrome, in which there is hyperstimulation of macrophage producing lots of cytokines. Now, well, this slide shows where this laboratory services come in this COVID-19. In epidemic surveillance, we know serosurveillance going on, anti-SARS-CoV-2 antibodies, diagnosis, RT-PCR antigen testing. Then for staging, prognostic, and therapeutic monitoring, this is where we are talking about the biomarkers. We want to pick out those biomarkers which will tell us that this patient will need critical care intervention, and he may have mortality, or he's like stable. So we these three: staging, prognostic, and therapeutic monitoring, we use biomarkers. So what actually is a biological marker or biomarker? It is a characteristic that is objectively measured and evaluated as an indicator of normal biological processes or pharmacological responses to a therapeutic intervention. So ideal biomarker expression should be significantly increased, especially in the related disease condition, and shown to correlate with an interested outcome progression. And most importantly, economical, quick, and consistent. You should be able to measure non-invasively this biomarker. So now coming particularly to COVID-19, we had some data from China when this virus came to India, and all these factors which is shown in the slides were known at that time also. That in severe COVID-19 or in patients with having moderate to severe symptoms, they had decreased serum albumin, increased CRP, increased LDH, decreased lymphocytes, increased ESR, D dimer, ferritin, and IL-6. Now the problem was, how specific are these biomarkers? Do you look at one biomarker? You do a panel of biomarkers, how frequently you do it, and what are the absolute cutoff values? They were nowhere mentioned. So what we did was WHO, I will show you the slide. WHO has already given one case reporting format with all those investigations. It included all those investigations. So we will routinely doing it without knowing what actually is the cutoff and what is the management we have to change if these markers are increased or decreased. No, so many studies started making charts. These are what happens to the markers as the disease progresses from mild, moderate to severe. So as you can see in moderate, mild, they have not mentioned anything. But in mild disease also there are derangements, we all know. In moderate, there may be increased WBCs, increased LDH, and severe. And if you see the number of arrows increasing, so the same parameters, the amount of derangement from the baseline is increased as the patient goes from mild to critical. No, this is like simplified version of that in early infection. Now, so patient on home isolation. So there is mild change in biomarkers which are non-specific. Lymphocyte counts may be decreased, D dimer is increased, LDH is increased. In fact, ferritin may be increased, and CRP may be raised. And there was a question when they said that is there a way, when there were a lot of deaths happening, that is there a way that in patients in home isolation we can check for any biomarker that if this is raised, they need to get admitted in hospital. So there was a question like this, but it was not recommended because they are very non-specific elevations of these markers. So it has to be seen in relation to the clinical status of the patient. It's not that the patient is having high LDH, admit the patient. And anyways, if with thousands of patients on home isolation with unreliable biomarkers, so how can you take sampling of all those patients just for one unreliable marker? You do not know what it is going to progress or not. But there are mild changes in biomarkers in mild infections also. Then in second, which is the pulmonary phase, 2A, 2B simply means that one without hypoxia and 2B is with hypoxia. Now this is actually the where we enter the moderate cases. So they have a utility. So AST, ALT levels may be increased. I will come to these individually also, these markers. Procalcitonin, this is a renowned biomarker of bacterial infection. CRP may be novel increased, ferritin may be increased, lactate may be increased. So this is in case of moderate cases. Now hyperinflammation phase or the cytokine storm, when there is ARDS, SIRS shock, then all these markers are increased, but the levels to this raise is much more as compared to moderate. And anti-pro-BNP, ferritin, CRP, IL-6, they are also much raised. So basically, there's only the degree of increase in markers is changing. Now, procalcitonin is the marker which we all, if you see all these markers, there's no novel marker for COVID-19. These markers we have been using for from before also, and that is the problem. What is there simply marker of infection, marker of inflammation, or do they have any prognostic value? So studies were done. And procalcitonin still remains the same, that it was due to differentiate bacterial infection from non-bacterial causes, and is associated with higher risk of severe COVID-19. Sustained elevation was seen in patients with ARDS and de-escalation of antimicrobial therapy. This is not new. This was done before also. Now, how do we use if a patient is admitted in hospital, we have to do procalcitonin level. What will we get? So blood culture, as you know, are unreliable. So best way to check for bacterial infection is procalcitonin levels. Secondly, if you wanted to put patient on tocilizumab, you need to know that patient is already not suffering from any bacterial co-infection. So we do procalcitonin levels just to have a surrogate marker that okay, it is safe to give this IL-6 blocker. So procalcitonin has the same role as before and nothing new in COVID-19. Then comes the IL-6. It also, many studies have shown it predicts progression of COVID-19. It is associated with COVID-19 mortality and useful in COVID-19 disease monitoring and predicts respiratory failure. So again, the problem with IL-6 or any other biomarker is where are the cutoffs? If you do the studies, every study has a different cutoff. When you say that you want to give tocilizumab, what should be the cutoff? Some will give 35 picogram per ml, some will give below that, some will give higher that. So it's just you do not know what is the exact cutoff value of IL-6 when you should start tocilizumab. Anyways, it is not no more in use because of its ineffectiveness in previous studies. So it leads to the severity of the disease by activation of the coagulation pathway, increase in the vascular permeability, and reduce cardiac function. Now, the major reason why this tocilizumab did not work was because just because IL-6 is raised doesn't mean that blocking it will reduce the severity, because there is a complete immunologic cytokine profile. You have to profile the complete cytokine and chemokines. It's not a single IL-6. This is not the key cytokine. There are many redundant pathways. You block IL-6, it will pass through other pathways. So some now study in Lancet is that they're saying IL-33 is the one you should block. So till the time we have this complete immune atlas, there is we don't know what cytokine to block. Now the other important markers is D-dimer. Now this is a marker for coagulation activation. This is again an old marker. We all know about this. Produced during degradation of fibrin protoplasmin, and this is a mixture of fibrin degradation products. And it is indicative of disease severity and mortality, D-dimer, in COVID-19. Now mechanism we also know, disseminated intravascular coagulation, sepsis-induced coagulopathy, or unknown. Now this unknown thing in COVID-19 is more important than the other two factors, because we have seen raised D-dimer in patients who are apparently clinically fine. They don't have DIC, they don't have any coagulopathy. You can see, patients are, even mild patients have some raised D-dimer. So the mechanism is unknown, but one thing is sure that if the D-dimer is increased, there is more chances that patient will need critical care. Now, so suppose you do a D-dimer of admitted patient, it comes raised. So what is the next thing you do? Hello? So if patient admitted has an increased raised D-dimer, what should you do? Some recommended, okay, start doing this Doppler ultrasound lower limbs to rule out VT. Now there is International Society for Thrombosis and Hemostasis, which has given specific guidelines during COVID-19, and they said no, you need not do screening this ultrasounds for detecting VT if D-dimer is raised, and put all admitted patient on thromboprophylaxis. So basically D-dimer in this does not necessarily mean patient is going to DIC or sepsis-induced coagulopathy, but it is a marker, simply a marker that patient may land able to critical care. And sometimes they say that it is also said that the D-dimer is very increased, like 6 times the upper limit of normal, with the sepsis-induced coagulopathy score of more than or equal to 4, then they may need long-term anticoagulation for 14 to 30 days post-discharge. Now, these are all in the guidelines which keep on changing. So increased levels are anyways associated with VTE, and we have seen cases of pulmonary embolism, but which patient go into embolism, even in patient on therapeutic anticoagulation have gone into embolism. So again, we have no like specific dosage of low molecular weight heparin or the level of D-dimer, but we know that normally 2 to 3 times D-dimer is normally raised in COVID-19 patients. Why this happens is mechanism is still unknown. And you should remember which assay you are using. The normal range will vary, and results are not comparable among the various assays. Now, another important marker is lymphopenia. And as the inflammatory cytokines increase, lymphopenia increases. The mechanism is that there is activation of apoptosis. Virus can directly activate apoptosis, as explained in the previous slide. And because of cytokine storm and there is recruitment of the lymphocytes to these sites, so this leads to depletion of lymphocytes. So, and serial measurements can be used as prognostic markers. In fact, all the markers which I am mentioning, single value is not of much importance, and serial measurements, if you see it is increasing or decreasing, you can get some idea whether the patient is responding to treatment or not. So serial measurement can be used as a prognostic marker. Now, the next one, which we use in the list, is the ferritin. Now, is it a simply acute phase reactant, or does direct damage to the tissue in COVID-19? Still not known. And increase in serial levels simply says that inflammation is persisting, and the patient is like can go into severe disease. The next marker which we are doing is LDH. Now see, I repeat most of these markers every 72 hourly, just to see the pattern, whether patient is responding or not. Otherwise, individually they have no role. A non-specific indicator of cellular death, and it is used as a COVID-19 severity marker and is predictor of survival. So this is a study that pooled analysis of 9 published study, especially on LDH. So they said that at the time of admission, the elevated LDH level were associated with poor disease outcomes. So there was 6-fold increase in odds of developing severe disease and 16-fold increase in odds of mortality if elevated LDH at the time of admission. So the patient has fulfilled the criteria for hospital admission. Then you are doing these prognostic markers. And in that, if they come, then this is what you can predict. Again, not in mild cases. The next biomarker, this is also a very common biomarker, C-reactive protein. It is correlated with the level of inflammation. It activates complement and has phagocytosis, and it positively correlated with lung lesions. Lung lesions that you are going for HRCT. Actually, HRCT, the oxygen saturation monitoring much more important than imaging the lungs if the patient is very sick, because you are not going to get much of a data. The only so you go in for these biomarkers only. The only reason you can go in for this CT scans or not, if you are suspecting pulmonary embolism, or the desaturation or the oxygen saturation is falling out of proportion to the clinical features or the X-ray findings, bedside X-ray findings. Otherwise, the patients are not sent for any CT scans routinely. So CRP and other use of CRP is like we use in pneumonia also to chart the course of and doses of injectable steroids which we give. So steroids can be tailored to CRP levels, and you can check levels of CRP while the patient is on treatment, that whether the inflammation is getting controlled or not, and you can escalate or de-escalate the steroid therapy. So CRP and steroid therapy, CRP may have some role in deciding the steroid therapy. No, this is the list of biomarkers which you all know that I've used in a previous slide, because you know these biomarkers are done. I have told you what is the importance and why do we do these biomarkers, what actually are these biomarkers. So this was the first form when the first patient of COVID came to like our hospital or we started treating. So from Chinese study, the WHO has already taken out this global COVID-19 clinical platform. So when the first patient came, we already had this chart. So see the parameters which they have written. So CRP, LDH, troponin, D-dimer, ferritin, IL-6, procalcitonin, they were there on the day one when the patient came to this our country. So what happened? No, different associations, different societies, different hospitals, they started using these biomarkers to define patient at risk, not at risk, by different combinations. So like in this, there is early clinical assessment of COVID-19 patient decision tree. They took LDH and HSCRP and then lymphocyte. So started like they gave definite cutoffs. So initially, if you go, the protocols which were devised, they were simple algorithms. But later on, it was found out that these findings may be available in the mild patients also. So it is not necessarily that these cutoffs are valid for all patients. So this is the problem. We could not make a decision tree based on these biomarkers later on. Now this is again another decision making algorithm which was published, like COVID-19. You took age, then neutrophil lymphocyte ratio, and then it's less than 3.3 isolation area, more than equal to 3.13 general isolation. So where the patient is being treated based on neutrophil lymphocyte ratio. So again, this was very specific. So early on, algorithms were very specific and it was very easy. Okay, it was all black and white. If this is there, send him to ICU. If this is not there, send him to home. But later on, we came to know that no, this is not the case. It's not as simple as these cutoff values which are being shown. Then they started combining many, like they needed some kind of score or parameter which will be, definitely tell them that the patient will land up in severe sepsis or patient will have a severe COVID-19. So various scores started coming up. Like this one was called store, which included comorbidity, age, lymphocyte, LDH, various levels of LDH, various cutoff values. So somehow combining 4 or 5 parameters to give a more reliable scoring system. Then finally coming to our own management protocol. See, when you do not know what is the proper management, it is not documented, or you do not know properly the role of the medicines which has happened in COVID-19. First is tocilizumab, then remdesivir was labeled as a wonder drug. So best is to follow the clinical management protocol. So in our Ministry of Health and Family Welfare guidelines, this is the line which is written: CRP, D-dimer and ferritin every 48 to 72 hourly if available. So this is what it speaks about the biomarkers. What is the interpretation? What are the cutoff levels? How do you manage the patient? How you monitor the patient? Using nothing, no statement in any of the revisions of clinical management protocol. If you go through it, you will not find anything except for this line, and that too, if available, you do it. Otherwise, so this is what they have written. And anyway, CBC, lympho, they have stressed on lymphopenia and KFT, LFT to be done daily. But this is what is in our guidelines. So in summary, I will like to say that it's a very complicated matter, that how you interpret these biomarkers. So you need not be overtly dependent on these biomarkers. They will simply tell you, give you an idea, inkling that admitted patient, not mild, admitted patient may land up into critical phase if these biomarkers are seriously increasing in collection or individually. Again, D-dimer in isolation is not in suggestion that patient has gone into DIC. IL-6 levels, if you are giving tocilizumab, yes, there is some recommendation, no defined cutoffs. And CRP, yes, steroid doses may be tapered, maybe tailored to the CRP level, so you give some sort of endpoint. And ultimately the clinical features, the saturation of the patient, the other biochemical parameters of the patient, they are to be taken in conjunction with these biomarkers. They should not be taken in isolation. Oh, iska D-dimer increase hoga, he's going to die. It's not like that. So we have to be very careful. They are still not proper cutoffs. We still do not know how to individually follow up the biomarkers. So it is a clinical acumen which will determine the state of the patient and what is the prognosis of the patient. Thank you.
Thank you, Dr. Vikas Dogra. It was a very, I'll say that it's a really a very wonderful presentation, because your way of speaking was telling your understanding, basically. So I was amazed that how, so I do not know whether it is a mathematics or whether it is a statistics or whether it is a combination of both mathematics and statistics, which will be important for this. I want to ask just one or two questions to you. That is, because you have, there is a long list and everybody has gone through the list of biomarkers. Related criteria for biomarkers which is associated with the sepsis or septic shock, or what is your practical experience, that what is the best practical approach which we like? There are different types of setup. In which setup, what practical approach can be used? So though you have discussed all these things, but I want that whether there is an objective criteria for biomarkers. Secondly, what is your personal experience for combination of these two, like practical approach? And third, which is very important, because now because you are saying that we are like the number of COVID patients are decreasing, but number of patients with the post-COVID patients, number of post-COVID patients will increase. So is there any biomarker for post-COVID patients? Because they have either saved out of sepsis, or they have saved out of septic shock, or they have saved out of some respiratory illness, some cardiac illness, or some renal illness. So these three things: objective criteria, then your practical experience, and third is post-COVID biomarkers.
Yes, sir. The practical experiences, sir, regarding different setups. If the patient is getting admitted, even in our guidelines is written, this monitoring is to be done in admitted patients only, not in mild patients. So if the patient is admitted, it is a COVID designated hospital or COVID hospital, they should have these facilities. Once patient is inside, they should have these biomarkers to, once the patient is admitted, to monitor the patient progress. Secondly, regarding the, and as I told before, sir, clinical features, what is the saturation of the patient, what is the support he's getting, NIV, HFNC, these are as important as biomarkers. It is not just simply looking at the report, you say, oh, his IL-6 is normal, no problem, no worries, and the patient is on high NIV support. So they do not correlate well. So we need to take both into account before prognosticating the attendance or checking the prognosis of the patient. And thirdly, sir, regarding post-COVID, now this is more controversial, even because we have some data about COVID, the post-COVID, but there are studies going on that there is persistent elevation of inflammatory markers who later on go on to develop pulmonary fibrosis or post-COVID manifestations. Even malaise and itself can be defined by that. TNF alpha is we suggested role. In fact, there is a study that if there is very high IL-6 level, these patients later on develop more pulmonary fibrosis. But as of now, more important biomarker is the patient has been in ICU, on ventilator, on NIV or HFNC. They are more liable to go into this post-COVID complication as compared to those who do not. So again, in post-COVID also, biomarkers are not that much reliable. See, IL-6 we are saying, then there is one KL6 marker also to check for alveolar damage. So there are multiple biomarkers that are coming up, but still I will go that the data suggests that the clinical feature and at the how much oxygen did he require, he was on HFNC or not, who was on ventilator, that will determine he will develop post-COVID complication or not.
So I think along with biomarkers, clinical condition of the patient is very, very important. So thank you so much, sir. It was really, it was an exciting topic which you dwell upon, and I think you did it wonderfully well. So thank you so much.
Thank you, sir. Thank you so much.
Thank you so much, sir, for the session. Right now, there were, I think, no questions regarding the session. So I will hand over the platform to Dr. Kirti, and she will take the next session. She will introduce the next session. So Dr. Kirti, please start sharing your slides.
Thank you, Dr. Charu. Good morning, everyone. Yeah, good morning, everyone. Myself, Dr. Kirti Nirmal. It's my privilege to introduce one of senior consultant, Dr. Shukla Das ma'am. She is Director Professor, Department of Microbiology. She is a moderator. She will be moderate this session.
Introducing the speakers.
So I am just going to introduce my speakers for this present talk. The present session is about fungal co-infections in COVID-19. Patients are worried. So I'm going to introduce Dr. Chavi. Dr. Chavi Gupta, she is MD microbiologist, DM infectious disease. Presently, she is as a consultant in Northern Railway Central Hospital, New Delhi. Ma'am has an area of interest in infectious disease, immunology, fungal infections, and hospital infection control. She has a 20 publication in national and international journals. Right now, she is actively involved in AIMS antibiotic policy app also. And now I'm again going to introduce my next speaker, Dr. Gagandeep Singh. Sir is Associate Professor in Department of Microbiology, All India Institute of Medical Sciences in New Delhi. Sir has done a lot of work in therapeutic drug monitoring, antifungal stewardship, and histoplasmosis and dermatophytosis. Sir has a major achievements in he has 80 publications in which 50 internationals and 30 are nationals. He had edited 1 book and written 6 chapters as well. So I am going to hand over session to Dr. Shukla Das ma'am. She will be moderate this present session. Over to you, ma'am.
Okay, hello everyone. I think you can hear me, and can you all see the slides? Can anyone just say yes?
Yes, ma'am. Shukla ma'am, you are audible.
Yeah, okay. So first of all, I want to thank everyone for organizing this workshop, and of course we are the host. I really want to thank Dr. Dogra for
Shukla?
Yeah.
Ma'am, aapka camera, please adjust your camera. Your face is not visible.
1 minute, 1 minute.
Yes, ma'am.
My just show the video.
Your face is
1 moment, 1 moment. My face.
Lower down your camera. Yeah.
Lower down the camera. The camera. Okay, just a minute. Yeah. Okay, just a minute. Okay, let me just start with the slideshow. It's all right. It's okay. Yeah. So I'll begin with my slides. So I was, 1 moment. Okay, can you see me now?
Yes, ma'am. Yes,
Okay,
ma'am.
all
Yes,
right.
ma'am.
All right.
Yes, ma'am, you are visible. Please, you can
Yeah,
start
so
sharing.
yeah. So I am 1 minute. Why is there? Okay, so I was switch off all these. So the Dr. Dogra's excellent talk has set the ball rolling, and we are now.
Your voice is echoing.
Yeah, I know it's echoing. 1 moment. So yeah, now I think it's fine. Now I think it's still echoing.
Ma'am, Kirti ma'am, you have to switch off your
mic.
Okay, now. So there was a little technical problem. So going back to Dr. Dogra's talk has set the ball rolling, and we all know that COVID-19 has led to an unprecedented burden to the healthcare system, as we have all seen. And this is the one. Yeah, so since it had laid a huge amount of burden, on the healthcare system, and Dr. Dogra very nicely said that the clinicians have faced an uncertainty in differentiating a hospitalized COVID-19 patient progressing to a fungal or a bacterial infection. There are several biomarkers, but there are no single indicator that tells you that the patient is just suffering from a severe COVID infection or is progressing to these bacterial superated co-infections. So, because of all these problems, there were no algorithms earlier set up in the hospital. We were basing our management on various advisories that were being given. And of course, clinicians were playing a very big role in managing their patients on one-to-one basis. Now, slowly what we discovered that, later on towards when the pandemic had reached its peak, we were suddenly flooded with so many newspaper clippings, and we were hearing that COVID-19 and mucormycosis, there was aspergillosis, there were a lot of other fungal infections that were getting reported. I think someone's mobile, someone has to keep it mute. Okay, so there were a lot of these fungal infections which were being reported, scattered reports. By then, I think the world globally, US, UK and China had already started on a longitudinal study where they had started reporting, and they were kind of had a protocol where they were looking for these bacterial and fungal infections in these COVID-19 patients. Why was this concern raised? This concern was raised because previously the clinicians and the scientists found that in influenza, it all began with the risk in influenza. The influenza associated aspergillosis, pulmonary aspergillosis, had caused far more mortality than influenza alone. So that is how the concern was raised. And adding fire to this fuel, these infections were getting lost. And why in Indian scenario there were not too many reports? Probably it was there was a lack of sampling technique, or there was a lack of infection control, or the clinicians were flooding them with empirical antibiotics, or was there a standardized protocol? As Dr. Dogra mentioned, there was no standardized protocol laid down for these infections to be monitored. So if you look at these parameters, if you see the percentages that have been found, actually, whether these bacterial or fungal, especially this is the session only for fungal infection, so whether this fungal infection were only as coincidental findings or they were attributable to COVID-19, this was unsure. So if you look at this data, we find that the non-survivors and the percentage varied from 5 to even 50 or 30 to 50%. So today's objective, the eye opener, we have very bright speakers today, where we are going to considering that 5% of COVID are critically ill. So what is the incidence and the mortality rates due to fungal infection in these patients? The risk factors for these fungal superinfection, what are the infections that are common? How and when are we going to suspect? So I'm sure these listeners and our participants are going to enjoy this session. And with this objective, we will place 2 speakers who's going to describe the clinical features, how to diagnose, how to differentiate between a colonizer or a pathogen, or not overtreat them. Any diagnostic algorithm can be built up today, and the role of empirical antifungals. Dr. Chabi is our clinician, has been introduced, suspicion in critical COVID and vigilance. She is going to tell us something about signs and symptoms, whether these are progressing to bacterial, fungal, or just the COVID. High inflammatory markers, you've already listened to him very well. And is that a reason to start empirical antibiotics and antifungals? Deteriorating functions or whatever. So the timing of the co-pathogen detection is very important. That is what we are going to strike upon today. When are we going to subject sampling techniques? And this area, the fungal co-infections that we are going to cover today will be Aspergillus, Mucor, Candida, Pneumocystis a little bit. These are the main ones. And these lab markers will be described by Dr. Gagandeep, a bright speaker from All India Institute of Medical Sciences. He will discuss upon the culture techniques and the non-culture techniques. And of course, he will definitely tell us whether these biosafety measures and precautions for handling these samples. So because probably these were the concerns that most of the laboratories were not collecting samples from COVID patients and subjecting them for identification. So with that, I now request Dr. Chabi to share her slide and begin her talk.
Am I audible?
Yes.
Ma'am,
yes, Dr.
Thank you, ma'am. Good evening. Good morning, everyone. I feel very privileged to be part of this workshop. I'm very grateful to Delhi chapter IIM for inviting me on this platform, and my special thanks to my UCMS faculty and Dr. Gagandeep from AIMS, who has made me capable that I am giving a talk on this platform right now. So right now we are on almost into 1 year of the pandemic. India being a densely populated country, we have lot many cases of COVID-19 infection, but luckily the mortality rates are very less from the European world. As Dr. Dogra and Dr. Shukla has rightly said that our guidelines mainly focus on the management of the COVID-19 patients, and the co-infections being a fungal, bacterial or any other are completely ignored from these guidelines. But now it's time to revisit these topics so that we can further modify our guidelines and make the better clinical management of our patients. So as you see, I will be mainly discussing on the fungal infections in COVID. Are we really worried? Let's start with a case scenario. So a 45-year-old female with a history of diabetes, dyslipidemia admitted in COVID isolation ward. On admission, her BP was 130/80, pulse rate was 100 per minute. Initially on room air saturation was 89%, which gradually improved to 95% on 6 liters of oxygen. So considering she was categorized into a moderate illness and was started on a standard protocol of injection remdesivir, dexamethasone and enoxaparin. Along with it, antibiotics were started, ceftriaxone and doxycycline. Initial routine investigations, only TLC was raised around 13,000. Rest, hemoglobin, platelets, liver function and kidney functions were normal. Inflammatory markers were raised, CRP, ferritin, D-dimer and IL-6, but it was not very highly raised. Now, during the course of her illness, the clinician noticed that her blood sugar started increasing in the range of 350 to 400 milligram per deciliter. Ketones were positive, and as per the arterial blood gas analysis, she was having metabolic acidosis. So she was diagnosed as a diabetic ketoacidosis, and the treatment was started on these lines of IV insulin therapy and normal saline. Now, fifth day, her saturation started falling. Oxygen requirement went up to 10 to 12 liters per minute. Chest X-ray showed worsening. She was shifted to COVID ICU. And the broad spectrum antibiotics were escalated to meropenem. On 10th day, she had fever spikes. TLC further increased to 20,000. There was worsening respiratory distress, and she was intubated. Again, routine workup was sent, which included routine investigation, inflammatory markers, serum procalcitonin, blood culture, ET aspirate culture, and urine cultures. Now, this is the X-ray. This is the initial day 5 X-ray, which shows peripheral opacities. And this is the day 10 X-ray, which clearly shows worsening, increase in the infiltrates, and some consolidation. So now, what is the cause of this sudden deterioration? Either it could be worsening of COVID ARDS, or it could be a cytokine storm, some secondary infection, sepsis, or ventilator-associated pneumonia or hospital-acquired pneumonia, we can say. So considering these differentials, she was started, colistin was added, steroid dose were increased, and there was a plan for tocilizumab awaiting IL-6 reports and other inflammatory markers. Now, are we missing anything? Could it be due to some other infection or some other differential? I would say yes. It could be a fungal infection. We should always take a suspicious in this case. But now, is there any role of empirical antifungal? Let's see further. So ET aspirate culture was sterile. Blood culture initially after 48 hours was sterile. Ferritin was raised. Procalcitonin was normal. D-dimer was also raised, but IL-6 was only mildly raised. So it cannot be, the clinical scenario does not fit into the picture of cytokine storm. And also we can see that bacterial infections are ruled out. Now the clinical condition remains static. There was no improvement. Chest X-ray show increasing infiltrates. So considering the fungal infections, now we should think of the sending some investigations for fungal. Ideally, it should have been sent in one place now. So serum biomarkers, galactomannan and beta-D-glucan was sent. Now, what are the risk factors for fungal infection? Why are we talking on this topic today? The common fungal infections that can be encountered in COVID-19 patients are CAPA, that is COVID-associated pulmonary aspergillosis, COVID-associated mucormycosis, COVID-associated candidiasis. The risk factors, it may be due to the COVID-19 related immune perturbations. As we have noticed, there is a severe lymphopenia, circulating T lymphocytes are reduced. Now, 5% of COVID patients are critically ill and require ICU patient. There are multiple devices in the ICU, use of mechanical ventilation, HFNO therapy, NIV, urinary catheters, central catheters, and most of these patients are put on broad spectrum antibiotics, and even some of them also require total parenteral nutrition. Further, we have noticed that steroid is the only life-saving drug in this COVID-19. All other drugs are only a supportive management. So there has been rampant use of steroids in COVID-19 patients, and most of the people are not aware of the actual dose and they have been using high doses. And further, there may be immunosuppression in form of cytokines, which may further lead to use of either pulse steroid. Pulse steroid is a very high dose steroid given to suppress the immune system in the body, or there is a use of tocilizumab. And also, as per the study reported from PGI, there is a high fungal spore burden in Indian ICUs. Now, we have always seen and has been listening to often that COVID-19 can have a severe illness in diabetes. Yes, I would say that COVID-19 and diabetes, there is a collusion of two diseases. And I think Dr. Dogra and Dr. Dharm will agree with me that while managing COVID-19 patients, we have noticed that there has been a hyperglycemic surge in pre-diabetics, diabetics, and obese. Their sugar reaches to the level of 500, 600, and there is also abnormal levels in other patients also. This is because COVID-19 can also trigger new onset diabetes by damaging to islet cell. So all these patients require very high insulin. They may precipitate at ketosis or ketoacidosis, and sometimes glycemic control becomes difficult to achieve because most of the clinicians and even patients are not comfortable with insulin infusion. And adding fuel to the fire is the steroid, which is the only life-saving drug in the COVID-19. Now, the concept of COVID-associated pulmonary aspergillosis has been mainly derived from the influenza-associated invasive aspergillosis. Going back to a decade, when there was a pandemic of H1N1, there was a sharp increase in the cases of influenza-associated aspergillosis. The cause was not known. Either it was due to the evolution of more virulent influenza strains, that is a pandemic H1N1 strain which was causing more severe pneumonia, or it was due to the improved diagnostic that as we are progressing, we have now improved diagnostics of fungal cultures, biomarkers, histopath, etc. So this is a study from European countries conducted in 7 ICUs over the period of 7 years. So out of 432 patients, invasive aspergillosis was detected in 19% of cases after a median of 3 days of ICU admission. So we can see even immediately after 3 days of ICU admission, patients have invasive aspergillosis, and if not properly or adequately treated, can land into a fatality. So on multi-regret analysis, influenza was found to be an independent risk factor for IPA. Now, why influenza predisposes to aspergillus? There is a local damage to tracheobronchial mucosa, disruption of normal ciliary clearance. Influenza impairs local phagocytosis. There is a reduced function of NK cells, lymphopenia, cytokine imbalance. So exposure to aspergillus at this critical time of reduced mucosal and systemic immune defense leads to invasive disease. Now we can see that there is a correlation between the influenza-associated aspergillosis and the kappa. Same picture here is occurring in the kappa, that there is a local damage to tracheobronchial mucosa being a respiratory illness, and there is a immunosuppression, lymphopenia, reduced number of T sites, lymphocytes, and increased aspergillus spore burden in the ICU. So the exposure of aspergillus at this critical time of reduced mucosal and systemic immune defense can lead to invasive disease in COVID-19 too. This is a paper which shows that there has been a defective host adaptive immune response in severe pandemic influenza. As we can see in this diagram, that there is a hypercytokinemia of the immunosuppressive cytokines, and again there are the impaired adaptive response. So now again the question comes in, when we should suspect such fungal infections. Is there any role of empirical antibiotics? Empirical antifungals should not be started, because as if we start abusing antifungals, then this can lead to the resistance, and we may land up in problem in future when we will be not left with no option. So now when to suspect. There is a worsening respiratory status in spite of appropriate antibiotic therapy and adequate ventilatory support, fever, continuous or recrudescent despite appropriate antibiotic therapy. There has been no specific time mentioned for the onset of kappa, as we have seen that over the period of time, the influenza-associated aspergillosis has been studied well, and they have reported that median duration of onset is 3 disease. Now, there has been some multiple case reports and series reported from the Western world. Earlier study from China has reported low rates of 3 to 25%. European countries has reported rates of kappa 20 to 35%, and the onset has been the median of 6 days, which may range from 3 to 28 days after ICU admission, and the mortality reported is 44 to 60%. From India, we still don't have any published literature. However, the people from the South India has been speaking in some conference that they have noticed around 16% of kappa cases. We are familiar with this age-old criteria of EORTC and MSG for diagnosis of invasive fungal disease, which categorize fungal diseases into proven, probable, and possible. But this criteria is mainly for neutropenic patients and cannot be extrapolated to kappa patients or influenza patients. For the diagnostics, this criteria requires histopath, culture, imaging, and biomarkers. Now, again, the COVID being a very severe illness, and the most of the healthcare workers are PPE while managing the COVID patients, and all centers do not have the facility of bronchoscopy. Thus, always there is a risk of aerosol generation during the bronchoscopy. So, bronchoscopy is not feasible for every case, to diagnose the fungal infection. Also, the only converted dedicated COVID center, all centers do not have a CT scan facility. And also there has been an overlapping radiology, which I will tell later on. But the biomarkers, these are possible if we can do in serum, but this diagnostic part will be dealt by mainly Dr. Gagandi. So these are the classical CT features of invasive pulmonary aspergillosis we usually normally encounter in our routine clinical practice. This is a halo sign. This peripheral consolidation surrounded by the ground glass opacity, and there is a air present sign. You can see a sickle-shaped cavity in a consolidation. But now, in COVID, as you can see these 4 images, there is a COVID ARDS, where we can see ground glass opacities, infiltrates, small micronodules, and mosaic attenuation. Now, if the bacterial infection is superimposed on the background of COVID pneumonia, there is hardly any difference we can make out. And similarly in kappa and CAM, that is the COVID-associated mucormycosis, although we can see that there is a much overlapping radiological features in all these diseases, but still it can give some pointers. So the blot proposed a criteria for invasive aspergillosis in immunocompetent patients admitted in ICU, which again categorize disease into proven, putative, and the aspergillus respiratory tract colonization. Now again, this criteria require compatible clinical signs, abnormal imaging, and the host factors. So it is also not again suitable for diagnosis of kappa. Considering this, in 2020, European countries and the ISHAM gave a consensus criteria for clinical research and guidance for kappa, which mainly involves host criteria, that is a positive temporal relationship between COVID positivity and the diagnosis of fungal infection of around 2 weeks. Clinical criteria are the clinical features, which I have already told. Abnormal imaging, that is pulmonary infiltrates not attributed to any other cause. Means we have to rule out COVID-associated, COVID worsening ARDS, any secondary bacterial infection. Again, the microbiological criteria includes proven, probable, and the possible. Now coming to COVID-associated mucormycosis. As we all know that mucorales are the virulent filamentous fungi which is ubiquitously present in decaying organic matter, soil, and India being a tropical country having high temperature and humid environment, it is conducive for the mucorale survival. Now, India has reported a very high incidence of this disease. The prevalence is around 0.14 cases per 1,000 population in India. Diabetic is the main risk factor. Pathogenesis of mucormycosis, phagocytes and macrophages play a role in the host defense and inhibit spore germination into the hyphal form. Now, impaired phagocytic function, as we see in diabetes or with the use of steroids, it promotes the fungal hyphal growth, and the mucorale fungal hyphae are the angioinvasive and can lead to thrombosis and necrosis of tissue. Interaction of COT-H3 protein at mucorale surface with GRP, that is glucose regulated protein 78 receptors on endothelial surface, promote angioinvasiveness, and further mucorale require iron for growth and virulence. How is diabetes responsible for increased prevalence of mucormycosis in diabetic population? This is because of phagocytic dysfunction. In diabetic ketoacidosis, there is a proton-mediated displacement of ferric from transferrin leading to iron load, which promotes fungal growth. And also there is increased blood sugar levels, which upregulates the surface expression of the receptor GRP78 and further leads to penetration and angioinvasiveness. Now, how is COVID-19 responsible? This is because the COVID-19 illness is more severe in diabetic patients, abnormally high blood glucose levels, use of steroids, immunosuppression, and there is an impaired immune response. Again, from India, there is no literature or data reported or published, but we have seen in newspaper clippings and that there has been increased reports of COVID-associated mucormycosis. Now, clinically, mucormycosis can have a varied presentation in the form of rhino-orbital cerebral disease, pulmonary, cutaneous, gastrointestinal, or disseminated disease. There is a relationship between predisposing condition and the site of infection. As we can see, predisposing diabetes ketoacidosis predominantly present as a rhinocerebral form, and the use of corticosteroids predominantly present as a pulmonary, rhinocerebral, or the disseminated form. So in COVID-associated mucormycosis, common presentations are the rhinocerebral and the pulmonary. There is a case report of reporting fatal gastrointestinal mucormycosis in COVID-19 patient. Here the patient presented with melena and a hemoglobin level of drop of 5.6. Now endoscopy revealed gastric ulcers with necrotic debris and biopsies confirmed mucormycosis. So I would say that every clinical manifestation in COVID patient should be taken as a pinch of salt, and every possible workup should be done so that appropriate diagnosis can be made. Now again, how to suspect? I will be mainly telling about pulmonary and rhino-orbital cerebral mucormycosis because these are the common presentations. Again, for pulmonary mucormycosis, worsening respiratory status in spite of appropriate antibiotic therapy and ventilatory support, continuous fever or recrudescent fever despite appropriate antibiotic therapy, hemoptysis, productive or non-productive cough. Now, rhino-orbital cerebral mucormycosis, the following can be a pointer like new onset headache, eye pain, facial pain, numbness, periorbital swelling, cellulitis, proptosis, blurry vision, diplopia, sinusitis, nasal crusting, or black discharge from nose. Now, coming to next case scenario. 58-year-old male with the comorbidities of diabetes, hypertension, and a prior history of interstitial lung disease. Admitted with the complaints of fever, shortness of breath for 2 days, SARS-CoV-2 RT-PCR positive, admitted in ward. On admission, again, BP was 130/80, pulse rate was 78 per minute, respiratory rate 24 per minute. SpO2 was again low on room air, and he was put on oxygen therapy. 6 liter. He required 6 liter to maintain SpO2 of 94%, and he had a high grade fever of around 101 degrees Celsius. Now, initial chest X-ray show bilateral peripheral opacities. Initial lab parameters were normal. Started on the standard treatment protocol again on remdesivir, methylprednisolone, that is steroid, enoxaparin, antibiotics, augmentin, and azithromycin. Within next 3-4 days, he had increasing oxygen requirements of 16 liter per minute. Further worsening, he was put on high flow nasal oxygen therapy around 40 liter per minute, and he again had a fever spikes of 100 to 101 degrees Celsius. Day 6, TLC increased 17,000, antibiotics upgraded to piperacillin tazobactam. Day 8, again rising TLC, teicoplanin added. Blood culture, urine cultures were sterile. Now day 10, oxygen requirement reduced. He improved. Oxygen requirement reduced to 20 liters per minute while still on HFNO therapy. X-ray shows improvement. Fever subsided and TLC started in declining. Now, but after 4 days, day 14, TLC again rose to 26,000. Again, high spikes of fever, 102 degree temperature. Now, even after 10 days of appropriate antibiotic therapy, there had been initial improvement, but the TLC is rising and again fever spikes are coming. What could be the cause? Now we can see there are the classical risk factors of diabetes, steroids, and presence of catheter. There is an ICU stay for more than 7 days, critical illness, and persistent fever even after 10 days of antibiotics. So is there any role of empirical antifungal in this case? Or what could be, what are the fungal infection now we can suspect in this case? So initial workup, inflammatory markers were raised. Procalcitonin was on borderline 0.5. Now the cultures revealed, urine culture revealed budding yeast cells, which was identified as a Candida auris. Blood culture revealed Candida auris, and it was diagnosed as a case of Candida-associated candidiasis. Sorry, COVID-associated candidiasis. Now, COVID-associated candidiasis. So, invasive candidiasis. Candida is a normal commensal on our human body, but the classical risk factors like diabetes, steroids, again catheters, use recipient of multiple antibiotics, total parenteral nutrition, length of ICU stay more than 7 days, surgeries, preceding invasive candidiasis, candida colonization of skin and mucous membrane. All these factors make the person vulnerable for invasive disease. Now, the catheters are the most common portal of entry where candida species form biofilms. Mechanical ventilation increases the risk of colonization in airways. Sepsis, septic shock causes translocation of candida from gut into the systemic circulation, which promotes invasive candidiasis. So all these risk factors can be present in COVID-19 patients. So candida infection should also be kept in a suspicious or differential diagnosis in such case scenarios. This is the study from India, multi-drug resistant Candida auris infections in critically ill coronavirus disease patient conducted from April to July 2020. Now we can see India has seen around 2.5%, 15 out of 596 patients, and almost all patients has received antibiotics, steroids, and were on catheters, central venous line catheters, and the urinary catheters. So 2.5% nosocomial candidemia was reported. Main species isolated was the Candida auris in the bloodstream, 10, and two patients also had a concomitant Candida auris in urine. The onset was probably seen in the from the date 10 to 48 days, 42 days after hospital admission. 70% isolates were multi-drug resistant, which showed 100% resistance to fluconazole. All isolates were sensitive to echinocandins. Next common species were albicans tropicalis cruzi. Overall mortality in 15 cases with candidiasis is 53%, while the Candida auris related mortality was 60%. This is a literature reported from European world of candidiasis and COVID, which has showed comparatively higher number as Indian population. UK has reported 17 out of 135 cases, and Italy has reported 3 out of 43 cases. So overall data of all the Candida COVID associated candidiasis revealed that invasive yeast infections among critically ill COVID-19 patients. Candida albicans was the most prevalent species, followed by auris and other glabrata, paraxylosis tropicalis. Most of the isolates are multi-drug resistant. Mortality high. High clinical suspicious is required. And as we all know that as we work in PT, it's very difficult to perform decolonization protocol for Candida auris in COVID wards in ICU. So there is a need for diagnostic algorithm. We cannot start empirical antifungals in each and every patient, or we cannot include empirical antifungals in the management protocol nationwide, because it will lead to abuse of the antifungals. So considering for this, a diagnostic algorithm is required, then how we should suspect and how we should diagnose. So the take-home message: India being a diabetic capital, high burden of fungal co-infections cannot be ignored. In critically ill COVID patients not responding to standard treatment, high suspicion is required because it can have a high mortality. It is difficult to differentiate between colonization and infection. Radiology, though there are overlapping features, but can give clues. Timely and appropriate diagnosis is the need of our, and there is no role of empirical antifungals in the standard treatment protocol. Thank you.
Okay, Dr. Chabi, thank you so much for that elaborate discussion on 2 cases. And without taking much time, the participants, if they heard the introduction, so she is one of the microbiologists who has done DM in infectious diseases. So I think the amalgamation of microbiology and clinical aspects are very useful in such situations. And now, of course, she has her teacher speaking today and taking over the diagnostic algorithm. Dr. Gagandeep, please, can you share your slides? And we'll take over take questions after this. Thanks.
Thank you, ma'am. I'll just share my slides. Hello. Am I audible?
Yeah, we can hear you.
All right. So I think Dr. Chavi has really made my job extremely easy, because she's very lucidly described 2 cases and how to suspect the most common fungal infections associated with COVID-19, that is invasive aspergillosis, invasive pulmonary aspergillosis, mucormycosis, and candidiasis. So I'll just briefly describe about what we need to do in the laboratory so that we are able to appropriately make a diagnosis. Although I think the most important point again we need to remember is it's the clinical suspicion, because once the clinical suspicion is there, only then will the clinician send us appropriate samples to make the diagnosis. The laboratory's job is probably only to confirm the clinical suspicion. So if you look at just go through the overview, that symptoms of some fungal infections can be similar to those of COVID-19, including fever, cough, and shortness of breath. So it's laboratory testing is important to diagnose those fungal infections. And as such, people with severe severe COVID-19 in the ICUs are particularly vulnerable to bacterial and fungal infections. And as I said, the most common fungal infections are aspergillosis and invasive candidiasis. So high clinical suspicion is required. Chavi has talk about these once again, that the clinical features are to be kept in mind. The fever is usually refractory in cases of COVID-19 associated pulmonary aspergillosis for at least 3 days. There may be recrudescent fever for 48 hours despite antibiotics. Other features like dyspnea, hemopsis, pleural rub, and chest pain do indicate towards kappa, and worsening respiratory function despite antibiotics and ventilatory support. Radiology she's described in detail, and I won't go into the details of that. Now, one very important point for making a diagnosis here are the kind of samples. So I'll be dealing one by one. If at all we can get a lung biopsy, that is, I think it provides a proof for invasive pulmonary aspergillosis. However, as in routine, lung biopsies are extremely difficult to do. There is risk of sampling error. It is usually CT guided biopsy, so sampling errors may be there. And being an invasive procedure, it's usually not preferred. Next comes the bronchoscopy with bronchoalveolar lavage. Again, it's an extremely good sample, but in cases of COVID-19, due to aerosol generation and contamination of surfaces, it's extremely rare that you get a BAL sample from a COVID-19 patient for with query diagnosis of kappa. So again, this is not, although the preferred sample, but it's not really preferred by the clinicians. Non-bronchoscopic lavage and tracheal aspirates are easy to obtain, but one of the major disadvantages is that none of our tests are fully validated for these samples. So this we have to keep in mind, that BAL is validated for antigen detection, for PCRs and lateral flows, but however the non-bronchoscopic lavage and tracheal aspirates are still not the validated samples. What we can really do is we can demonstrate fungal elements, we can obtain cultures, and maybe we can show if the titers for the antigens are very high, then maybe we can have some indication. Sputum again not a preferred, especially in cases of patients suspected of kappa. Serum can be useful. It's highly indicative for invasive pulmonary aspergillosis if you're using a galactomannan, a lateral flow assay, or even the PCR, and it's a validated sample. And also 1,3-beta-D glucan assays can be performed, and even PCRs can be done on whole blood. So but there are one major disadvantage is that there is variable performance, especially in the non-neutropenic group. So again, easy to obtain, gives almost reliable results, but still it has some pitfalls. Now this is the the guideline that was given forth by the ECMM and the ESHAM for the diagnosis of kappa, and it broadly follows the EORTC, MSG, ERC guidelines, where we broadly divide them into proven, probable, and possible kappa. So as we all of us know that for proving a case of invasive pulmonary aspergillosis, if at all there is a histology sample or an invasive sample that is there, and if we are able to demonstrate fungal hyphae, or we are able to culture aspergillus from those samples and perform PCR. So any of these or a combination gives you a case of proven COVID-associated pulmonary aspergillosis. However, this is extremely rare because it's very rare that we get invasive samples or samples like lung biopsy from these patients. So most of the times we end up making a diagnosis of probable or possible kappa. There is a long list of tests. I won't go through each, but I'll just broadly describe. And so for making a diagnosis of probable kappa, we need to have imaging and clinical factors clubbed with microbiological support. So imaging and clinical factors, Dr. Chavi has already discussed in detail. I'll just be discussing about the microbiology part. So if we have BAL samples and if we are able to demonstrate septate hyphae in those samples and culture aspergillus from a bronchoscopic sample, we can make a diagnosis of probable kappa, or we can perform galactomannan antigen test. It can either be, ELISA format or the lateral flow, which is available these days. Or if we are unable to demonstrate in the samples directly, we can even, if twice you have a PCR positive, or if 2 times from a non invasive sample you have aspergillus growing, that again gives you an indication that probably this is a case of probable kappa. As far as a possible case is concerned, possible case is, we usually don't have, we have the clinical features and the imaging in place. However, possible cases of kappa are only made when, if you can see here, if there is a non-bronchoscopic sample where you can you can demonstrate directly septate hyphae along with the culture, and or if you're galactomannan, if you're performing an ELISA from a supposedly a mini BAL, so and that has index of more than 4.5, 4 to 5, so that is a case of possible kappa, and the other criteria to this. So this is broadly the consensus that has been given forth by the ECMM Ishan. So next, I'll just like to talk about three important point of care tests that have become available in our country, and one is the IMI aspergillus galactomannan lateral flow assay. I'm talking about the point of care tests because these are extremely useful, because any lab, any microbiology lab, if you see, we perform galactomannan maximum, it's usually twice a week or maybe once a week. But these tests, which are now fully validated, FDA approved, if these are available, they can be useful in making a quick diagnosis. So the IMI aspergillus galactomannan lateral flow assay, it is right now approved for serum and BAL. It has a very short turnaround time of around 45 minutes. Sensitivity and specificity, you can see it ranges between 91 and 97% and 92 to 98%. So pretty good sensitivity and specificity. Even the negative and positive predictive value can go as high as 99%. We've just started using this kit, and one major drawback of this kit is that the reading has to be done via a reader that is provided by IMI. You cannot read it manually, especially for the mild positives or the low positives. It's difficult to record them manually. So the reader is required, and reader itself costs somewhere around 40 to 50,000 rupees. And again, another test, the OLM Diagnostics, it's a UK based company. They've again come out with another lateral flow assay. The IMI Sona galactomannan, it detects the galactomannan as the name suggests. However, the OLM Diagnostics, the ASP LFD, it detects manoprotein specific for aspergillus. So it's it's little different from the antigen that is being detected. Again, it requires very less pre-processing, and you can have results in as less as 15 minutes. And again, it is proven efficacy in cases of invasive pulmonary aspergillosis. So these are two tests which are right now available in the country and can be used for making diagnosis of invasive pulmonary aspergillosis. Again, this is I'll be talking about BDG again when I talk about invasive candidiasis, but Fungitel or the beta-D-glucan is useful even in making diagnosis of invasive pulmonary aspergillosis and even Pneumocystis jirovecii infections. So Fungitel, any of you who've used Fungitel in the normal format know that it's, the entire plate has to be used. It's extremely expensive, and the turnaround time usually it's from days to weeks, because and ultimately hardly the patient ever benefits from a Fungitel, because you have to wait for a minimum number of samples to be with you. Only then you have to put up the plate. So they have come out with this single sample format, which is known as the Fungitel stat. So it tests a single sample at a time. There's flexibility of testing. It's a rapid test, so you have the results available within an hour or so, and so eliminating the need for expensive send-out surfaces. And it is the first and only FDA cleared and CE marked single test for BDG, and it has reliable cutoffs, and it detects beta-glucan from most fungi, including Candida aspergillus and Pneumocystis, and there is a decreased turnaround time, so no more waiting for large batch samples that need to be run. But one major disadvantage of this test is that each test, even if you don't include any other, the labor or the glassware that you use, the test is around 7,000 rupees per sample. So that is one of the major disadvantages of this test, that to do it routinely is it requires a lot of administrative support or financial support. So once I'll just touch upon the treatment. Once a diagnosis of kappa is made, so if at all the susceptibility is possible, so if and we are able to demonstrate that the isolate is azole sensitive, we can go ahead and treat the patient with voriconazole or isavuconazole. And if at all the liver enzymes are being deranged, or for any reason you are unable to use azoles, the second line is the liposomal amphotericin B. Then if we can show that the sample or the isolate is azole resistant, so azole resistance is suspected, we can go ahead and treat the patient with voriconazole plus enokinocandin. And if at all it has been demonstrated in vitro that the isolate is azole resistant, so liposomal amphotericin B again can be used. We always highlight the importance of therapeutic drug monitoring, because there are a lot of drugs that we give might be interacting with the drugs, the azoles that are being given. So therapeutic drug monitoring should be done in especially in cases of voriconazole. Dr. Chavi had even spoken about invasive mucormycosis and COVID-19. I won't go into the details, but one of the major predisposing factors are patients on steroids and also the IL-6 inhibitor, that is the tocilizumab. And I'll club together the diagnosis of candidiasis and mucormycosis in the end. So a lot of reports of candida from India as well as abroad, and even Chavi had discussed about these cases, that they were, there was multi-drug resistant Candida auris infections were shown from multiple centers in Delhi. And again, just to highlight that they're relevant clinical factors, I don't think so per se COVID-19 is increasing invasive candidiasis, but because those patients usually are, they have prolonged ICU stay, they mostly have central venous catheters and are on broad spectrum antibiotics. So these are the factors which cause COVID-19 associated candidiasis. So it's just because that the patients are in the ICU for a long time. So that is why we are seeing COVID associated candidiasis. It's not that per se the rates for candidiasis are increasing. So if you look at this algorithm which was published in Mycopathologia, so if you have the appropriate risk factors, if it's a invasive sample for invasive candidiasis, and you can demonstrate yeast and pseudohyphae on calcoflora, blancoflora, even direct KOH, that gives you a proof that you're dealing with candida, and culture from blood or any other sterile site. Serology, again, Mannan, anti-Mannan antibody can be used. A combination is usually what is recommended. Mannan and anti-Mannan antibody usually have a sensitivity of around 50 to 60%. But when Mannan and anti-Mannan antibody are clubbed together, the sensitivity goes up to somewhere around 85 to 90%. There are a lot of PCR based tests available, and even the T2 magnetic resonance machine, which is basically an MRI based detection system for Candida in the blood, and it has a turnaround time for around 3 hours. So these are the basic tools that we have for making a diagnosis of invasive candidiasis. A few things which need to be borne in mind when you're dealing with Candida or you're suspecting Candida is then at an appropriate volume of blood, as much as possible should be sent, because lower volumes usually they lead to negative, false negative results. If at all possible, fungal specific bottle such as mycosis ICF by BD, it's there, which is specifically used for isolation of fungi from the blood or from sterile sites. And also you can increase the incubation period of the bottles that you've kept in the Bactic machine or the Bacti-Alert. So these will definitely help in increasing the isolation of Candida from blood or sterile sites. Regarding treatment guidelines are all the same. That first line, because we are dealing with the COVID-19 patients and most of them are actually sick, so echinocandins are the preferred drugs. They are cidal drugs. They are fungicidal. They cause very less derangement of liver functions and renal functions, and so triazoles should only be given if at all the echinocandins are not available. One major disadvantage of echinocandins is that they are on the expensive side, so many hospitals don't use echinocandins per se. Fluconazole is the first line that is used, or amphotericin B, especially in pediatric age group. Next is, I'll talk about invasive mucormycosis. Again, diagnostics. Again, there is no specific additional tool. Only thing is there has to be a clinical suspicion. Only then the clinician would send us the sample. So if at all it's a lung biopsy, CT guided FNAC is there, or there is a bowel sample and you can demonstrate broad aseptate hyphae, it's almost certain that you're dealing with case of invasive mucormycosis. Even in rhino-orbitocerebral, mostly it is a FES sample or a direct biopsy from the nasal area, and you can demonstrate broad aseptate hyphae, or even on histopathology, if you can demonstrate the broad aseptate hyphae on PAS or GMS. Culture, again, culture is usually difficult to isolate. The culture positivity in untreated cases of mucormycosis is somewhere around 50 to 60%. So direct demonstration, I think, does hold a lot of importance. Molecular identification, there are a lot of PCR based assay available, but availability is an issue. Hardly any center is doing molecular identification in routine. Cryptococcosis and pneumocystis are really not very important, and routine diagnostics are what are being used in routine. So that is it.
Okay. Thank you, Dr. Gagandeep and Dr. Chabi. Dr. Gagandeep, you have really covered it very well, especially it is the practical aspects, and you are coming from a premier institute where you are dealing with these investigations, so that you were the right person to have delivered this talk. So that was wonderful. We will have a few questions, I think, later on, because the time is, we have to cover 2 more sessions. Can we take the, I request all the speakers to be online. At the end of the session, we may have some questions and which will be addressed. Dr. Binita can take over. Dr. Binita and Dr. Nadeem.
Yeah.
Dr.
Good afternoon, everyone. I am Dr. Nadeem. I'm working as assistant professor in the Department of Microbiology, University College of Medical Sciences. I would like this topic for this session is TB COVID-19 co-infection, a phantom menace. And the moderator is Dr. Binita Kashyap ma'am, and the expert is Dr. Ashwani Khanna sir. Dr. Binita Kashyap ma'am is professor in Department of Microbiology, University College of Medical Sciences and GTB Hospital Tuberculosis Laboratory, and is also working as Hospital Infection Control Officer. She has more than 100 publications to her name in both national and international journals and several book chapters. We are very privileged to have Dr. Ashwani Khanna sir on board for this workshop. Sir has done a lot of work in the field of tuberculosis and respiratory diseases and is amongst the most reputed pulmonologists in Delhi. Sir is currently working as consultant pulmonologist at local Prakash Hospital, New Delhi since 1996. Sir is also working as a state tuberculosis control officer since February 2014 and is very active in the treatment and control programs related to tuberculosis in the city. Sir has more than 60 publications to his name in both national and international index journals, and currently is working on 6 research projects related to tuberculosis and respiratory disease. I would now request Dr. Binita Kashyap ma'am to share the mic, please.
All right. Good afternoon, everyone. I welcome you all once again. This is the third session in the event, Tuberculosis COVID-19 co-infection, a phantom menace. Now, as considered by the WHO as public enemy number one, coronavirus disease 2019 brought chaos to the healthcare system across the globe. And suddenly humanity was faced with a deadly new pathogen that was capable of spreading very aggressively and quickly through the host immune. Although the COVID-19 second wave has continues haunting some of the nations that already seem to have overcome the pandemic, but few countries still remain hostage to the SARS-CoV-2. And especially in Southeast Asia, South America and Africa, the crisis may even become worse because this COVID-19 disease may end up converging with another deadly disease that is prevalent, that is tuberculosis. The potential impact of tuberculosis on COVID-19 on TB patients or services continues to generate significant attention. Several concerns have been raised, but scientific evidence remains modest because COVID-19 disease obviously is relatively new and it is still evolving, and we need some more time to have some good quality assured scientific data. But as unlike COVID-19 disease, which is, which we are still struggling to understand, TB has been there since prehistoric ages, and it has been haunting mankind for more than over 70,000 years. Though tuberculosis continues to persist as the leading cause of infectious disease worldwide, since April 2020, COVID-19 has brought equal number of daily deaths throughout the world. So the consequences of this pandemic, COVID-19 pandemic, has really posed serious threat to the TB control program that is running in our country, not only in terms of the diagnosis, but also the treatment of this disease. Because of the symptomatic similarities between these two diseases, the countries with a precarious diagnostic structure have actually failed to identify these two diseases properly, thereby affecting the therapeutic decision making or thus impacting the final prognosis of these two diseases. So it's very clear the urgency of having more and more studies on this co-infection, because we do not still have enough clinical data to support this, and the initial published case reports or cohort studies suffer from significant limitations. So I could not have really thought of a better expert on this topic than respected Dr. Ashwani Khanna sir. Sir is the program Delhi State Officer for RNTCP, and sir was into the program. He knows the program in and out, and obviously the challenges that he's faced throughout this COVID crisis. So, but before we request sir to enlighten us on the subject, let me just hurriedly take you through what is already known, or what knowledge we already have about this co-infection, this deadly association between these two pathogens from the little literature that we have. So, just share my slide. Yeah. So, first of all, we must remember that the simplest explanation often is the most probable in medicine, which was often quoted as Occam's razor. This was a simplistic approach, which meant that all the symptoms present in a patient can be attributed to a single disease. Now, this held well for many centuries in the past, but now we are living in an era of increased focus on diagnostic errors. And the counter argument in medicine to this is Hickham's dictum. Hickham's dictum means that it means that a patient can have as many diseases as he damn well pleases. That means Hickham's dictum actually advocates disease plurality in a single patient. While keeping this in mind, when we deal with this deadly co-infection, we would take you into the insight of a neglected paradigm of a long-standing infectious diseases. Amidst this ongoing COVID-19 pandemic, we all know that multifaceted approaches are already in place to deal with this pandemic, but few correct steps can be taken at the right time, and that can help us to better contain this deadly association between these two pathogens, and can also help us to prevent the ill effects that would occur by missing certain potential suspects of tuberculosis. So let's see what we already know about this disease. We all know it's a global threat. India carrying the highest burden of COVID-19 disease in the world. Interestingly, the presentation of COVID-19 is quite variable, but conspicuously TB mimics the presentation, and these two organisms actually have high affinity towards the lung tissue, and they share some of the important host protein interaction partners. So in general, what has been the global impact of global impact of this pandemic on TB services? In general, there has been a decrease in TB diagnosis and the infection, TB disease and the infection diagnosis. The prevalence of TB in COVID-19 patients that has been reported in various literature ranges from 0.5 to 4.5%. And if we consider the risk of death or the recovery, the risk of death is 2.7 times, 17 times higher than in COVID patients with TB as compared to those without TB. Whereas the recovery, if we consider, the recovery is 25% times lower in COVID patients with TB as compared to those without TB. Now, if we relate current TB or previous TB with COVID-19 deaths, the adjusted ratio for the same is 2.7 for current TB, whereas for previous TB it is 1.51. There was a global tuberculosis network which summarized the findings from initial 49 cohorts of patients with previous or current TB and SARS-CoV co-infection. This reported an overall case fatality rate of 11.6%. They said that in approximately 53% cases, COVID was diagnosed after previous TB, whereas 28.5% patients had COVID-19 diagnosed before TB and 18.3% were diagnosed in the same week. While 85.7% patients were under treatment for active TB, around 15% were suffering from some kind of post-treatment sequelae. A systematic review was done on the current literature that is available on TB COVID-19 co-infection, and they have also summarized a few findings. So let's just see what they say. First is that they say that both active and previous history of TB not only relates to the increased risk for development of COVID-19, it also worsens the prognosis of this disease. They say that the prognosis is poorer among elderly people. It increases the susceptibility to COVID-19 and the severity of the symptoms. They further reinforce the deleterious role of TB over COVID-19, associating the co-infection with greater risk of morbidity and mortality. They have further reported that both the previous history of TB, current TB, and TB associated with HIV, all these increase the risk of death in patients infected with COVID-19. They have said that the relationship between TB and the TB is related to the worsening prognosis of COVID-19, and COVID-19 worsens the progression of TB. Co-infection has been reported to be particularly dangerous for people in conditions of social vulnerability, the elderly, and people with other comorbidities like diabetes or hypertension. So these were some of the salient findings from the existing literature and the global work that has been done on this co-infection. We still have, as I told you before, we still do not have much data on this. So without any delay, I would like to invite Dr. Ashwini Khanna sir to further elaborate on this topic. I'll just stop sharing the slides. Sir, please, I welcome you all. Welcome to the session.
Okay, thank you, Dr. Binita. Can you hear me?
Yes, sir.
Audible, sir.
I'll start the share screen.
Yes, sir.
Okay, first of all, I think I would thank the organizers for having me talk on TB and co-infection. It's an important topic because the TB program is an important program of Government of India, and it's being monitored very closely by the PM office. And what we have done is we have a task of eradicating TB by 2025, 5 years ahead of the global targets. So with this pandemic on, we are now stuck up with a decreased finding of these cases whom we can put on treatment, and it has interfered with our progress towards this elimination goal. So Dr. Binita has, I think, already covered quite a bit of what I need to talk, but I'll rush through it. And I think you all know that we have 27 lakh cases of TB every year. We contribute really 1/4 of the burden. We have a large percentage of nearly the same amount of MDR TB, which we are treating in India. But what does the TB and COVID pandemic has done? As Dr. Binita, I think, already said, these are two main causes of death among the infectious diseases worldwide. And at present, both diseases, as you all know, share same clinical features, which impairs its diagnosis and therefore its treatment. And TB is a risk factor for COVID-19, and the co-infected individuals have a worse prognosis. And many of the damages which we see in the co-infection are a result of the exacerbated inflammatory responses. Both these diseases together, they generate what is a self-sustaining feedback, which impairs the functioning of the lung. And large number of studies are trying to see what are the interactions between these two pathogens. And some of the first case reports show there's a worsening of respiratory symptoms in these two when both the diseases are together. However, the data from the cohort studies show some conflicting results. And I think Dr. Vinita has very clearly said, we are still looking at the data, we are analyzing it, we are still not really sure what is happening. But from the immunological perspective, the TB COVID co-infection has a potential to converge into a perfect storm, and these disorders are induced by each pathogen to immunomodulation, which tends to induce unbalanced inflammatory response and which can promote the progression and worsening of both the diseases. Understanding the nature of these interactions between the two will be crucial for the development of whatever strategies we need for treatment of both these diseases when they occur together. The review of literature which we have points towards association between TB and COVID-19, and both active and the past history of TB are related to increased risk of development of COVID-19, as well as worsening of the prognosis. But there are few clinical trial data on TB co-infection, and some of this, whatever literature we have a significant limitation. And in general, there's very small studies, and most of these studies are conducted not in India. These are in lower TB burden countries, and the clinical features are not well described. But despite this limitation, the reviewed studies offers evidence and support that TB contributes to the susceptibility and worsening of COVID-19. However, it's worth mentioning that other factors like social conditions, comorbid conditions, elderly, access to healthcare, they directly influence the prognosis of TB and HIV co-infection, which is there anyways in this TB disease without even COVID. So while the experience of COVID-19 infection in TB remains limited, it is anticipated that both the patients with having both the disease together will have poor treatment outcomes. especially if TB treatment is interrupted. So there we have to ensure that the drugs are not stopped, patient continues taking treatment, and we have to ensure the drugs are made available to these patients. Besides that, all the TB patients, they should follow all the advisories which are there to prevent having TB infection, COVID infection. And the patients who are people who are ill with COVID and TB show similar symptoms like cough, fever, difficulty breathing, and both affects the lung. And both of them are because of close contact, but the incubation period is, of the diseases TB is much longer, but we have with a slower onset. And large number of patients who have TB or have recovered from it, the old past history, how it ends up with scarring of lung. They have a compromised functioning of the lung, and this affects the COVID-19. Those people affected by COVID-19 can have a devastating effect on this type of patients who have a scarred lung. It is estimated that more than half of the TB survivors, either the post-treatment sequelae, have both pulmonary dysfunction in form of obstruction and restriction, despite a cure. A cure is there when you are the bacilli are no more there, you have cured the patient of disease, but the sequelae is leading to these dysfunctions. And except patients who are affected with this are, are more susceptible when they are having superimposed COVID infection. And SARS-CoV might additionally negatively affect the T-cell mediated immunity, which causes, as has been discussed earlier, lymphopenia, particularly in a severe form of disease, and it can potentially reactivate TB, which is latent, or render a patient of COVID-19 more susceptible to acquiring a TB infection from a person who's already infected because of this T-cell mediated immunity is low here. So TB treatment for co-infected patients remains the same. There's no difference between the treatment. It continues, the same drugs are used as per the WHO guidelines. But we must ensure that all these patients who are, including those who are in COVID-19 quarantine and those who have confirmed TB, they continue with the therapy. And to make this, we have to make the stocks are made available and to provide them at home, the ones who are not able to come there, so that they don't have to visit the treatment centers unnecessarily to collect medicines. And we have made the provision, which I'll talk about it later. Besides this, TB preventive treatment in form of INA prophylaxis or the treatment in case of drug susceptible and drug resistant TB should be continued uninterrupted as per the national program. Regarding the BCG vaccine, there is a talk, I think everybody's aware, we talked about BCG vaccine having a protective value. But this correlation between the beginning, you have universal BCG vaccine in the country and the protection against COVID-19 suggests that these BCG might confer long-lasting protection against the current strain of coronavirus. However, we need some randomized controlled trial using BCG to determine how fast the immune response develops, whether we can give it right away and have it and protect against BCG. But the BCG, as you all know, is an innocuous injection with minimal local side effects. But however, this BCG cannot be given in immunocompromised people as well as pregnant women. So care must be taken while applying this possible intervention in case of COVID-19. So what is about the COVID-19, the pandemic everybody is aware of, and I'll talk about what is the response and how we have tried to mitigate the problem which are faced by the program countrywide. You all know the first case was detected in January 30th. Entire country is covered, has reported cases. The number of cases are, as you can see, crossed a crore. We have roughly 170,000 active cases of today, and a large number of these people who have got the disease have got cured. But there has been a significant mortality of roughly 1.5 lakh people, deaths which have taken place in India over this period. And the vaccination has picked up, and roughly 22 million people are already been vaccinated as of now. So what was the impact of COVID on the TB services? I think this is important because this is where the TB services have been hit, and the nation, the Central TB Division, the Government of India has tried its best to have the services in place so that our goal towards 2025 eradication is not affected. So what has we've seen over a period of January to October, there are every year we detect something like 25 lakh, 24 lakh cases we have been detecting, but there has been a fall of roughly 5.5 lakh notifications. We had in this period last year about 20 lakh notifications, but this time we had about 15 lakh notifications till now. Not only were the notifications decreased, there was a total molecular test, what we are dependent on, the CVNAT and the TrueNAT, there has been 54% decline in these tests also. And this has affected molecular diagnosis. So I mean, number of people we are not testing that high. Now this, the reason we'll talk about later, but there has been a significant decline in the number of tests for detection, for molecular detection of bacilli. Besides that, what has happened because of this COVID-19 pandemic is that personnel who were working for national program have got engaged in COVID-19 activities at all levels, both at administrative, technical, as well as service delivery levels. So what is the impact of pandemic? What we see that drug sensitivity numbers in 2019 were 1.8 million. It has fallen to 1.3 million in the same period this year. And this decrease is nearly 28%. Amongst the drug resistance, we were detecting in the same period with over 40,000 cases, and there has been 10% decrease over the same period last year. But this decrease has been significant in pediatric age group. You know, the notification has gone down by 35%, which is in pediatric age group, and in adult age group, it's about 27% decrease. But every year, you follow the pandemic over the time from January onward, we were having the rising in detection of cases, the notifications were improving. But then when the February came, then you can see there has been 25% fall, and a major fall took place between March and April when the pandemic was very high. And gradually when things started increasing, the number of cases increasing. So these ups and downs have been there as the pandemic progressed in the country. So what was the setback to the health service during the pandemic? There were closure of facilities, including the private sector. As a matter of fact, the private sector, most of single unit, clinics, which contribute really 1/3 of a notification of TB in India these days, were closed. Private practitioners were not attending their private setups. Transportation was affected due to lockdown, and the patients were not coming to the setup for for the centers, which were also closed at times, and specimen transportation affected, and the drug supply was also affected at places. Human resources and infrastructure were diverted to COVID-19. And this was quite a major setback. In Delhi also we felt where a large number of our lab personnel was shifted to for COVID response in the as a matter of fact, at time half of our lab staff was functioning was with the COVID for the COVID response. And there was a heightened stigma towards the people who were showing both COVID and symptoms. So the diagnostics became a challenge at times. So what happens in care seeking? The patients were not approaching the OPD and a critical stage due to stigma, or they were going in late there, and patients who were having symptoms of fever and cough, which could have been TB, were referred to COVID-19 assessment and testing, obviously, but there was a decreased, delayed in finding in these cases who had tuberculosis. Regarding screening, as you all know, in most of the places, routine OPDs were not functioning in most places, in large number of places, and only providing at times emergency services. Staff was not coming, transportation was an issue. Now for diagnosis, we had 135 CVNAT, machines which were under the program in country, which was diverted, including 367 TrueNAT machines for COVID testing. And this was helped by providing them with the cartridges and the chips for detection of COVID-19. There was like I said earlier, there was 50% decrease in CVNAT testing for TB. And the treatment was interrupted in supply of drugs at places, especially there was a high COVID load. So there, few of the sites, they had an interruption of drug supply. This was not in Delhi, but they're part of India. And there was decreased monitoring for treatment adherence. We were not very sure whether the patients were taking treatment or not. And I think you must be aware that there's something called a Nikshay Poshan Yojana, where all the TB patients are given 500 rupees a month during the treatment. And this was given only to 35% of the patient during 2019 as compared to 61% a year prior to that. Besides that, a lot of letters came from mitigation adopted, and responses, and a lot of letters came from Government of India to prevent the TB service from affected badly. The COVID-19 pandemic had really affected the services of TB badly, because there is what we do is dots where the patient has to go at regular interval to take drugs from the dot center. So we have to take care of that. Besides, we were getting regular guidance how the TB services were maintained. This was from the very beginning. And besides that, there was a rapid response was done to mitigate these adverse effects of pandemic on the TB services. So what basic mitigation measures were being done? There were advanced directives to ensure continuity of TB service and review with states and districts. So we continued looking at it where that services were affected to give support to that thing. Then the guidance to the lab diagnostic remaining functional. Otherwise, what was happening is if we have no labs functional, we'll have no diagnostics. We have no diagnostics, the number of cases go down. And to make sure, initially the lab technicians were very, very skeptical about doing these tests. So we made sure that we had PPEs available for the lab staff. And there was provision of extended duration of drugs. Like I said earlier, the treatment was dots, but it was here. What we did was we gave them drugs for 1 month at a time. And we followed up these patients on telephone to ensure that they were taking drugs. And at times when the patients could not come to take drugs, the drugs were delivered to the patient's home to make sure that there was no discontinuity of therapy. And there was a synergy also between COVID and TB in form of human resources, diagnosis and treatment. In human resources at the national level, the technical assistance was provided by the program for strategies which were aligned to national policy for combating the disease outbreak. At the state level, the resource pools of trainers was there and adoption of guidelines to the local context. And at the district level, there was licensing for developing surveillance strategies and support in undertaking contact tracing activities. In the diagnosis, we were decentralized COVID testing with indigenous TrueNet labs and utilizing the CBNAT lab to increase testing capacity. We made CBNAT machines available at some medical colleges. The TrueNat also was made available along with the chips to augment the diagnostic capacity of the state, and then leveraging the TB containment facilities and supporting institutional-based screening also was done in the diagnostic part. And for the treatment, we have drug-resistant wards, which are used as isolation wards in certain sites. Nikshay was used for, Nikshay is our online portal, and where the call center service was leveraged. Calls were made for these COVID patients. Roughly 5.3 lakh COVID-19 calls were handled. And then IEC activities was also done using the TB platform. So besides that, the protocols were made. How do you manage a patient who had TB and was suspected of COVID, or the ones who were having COVID, how to evaluate for TB? And this was done in all the states, but some of the states have had the difficulties with them. So this is what was the TB patient screening for COVID. There was an algorithm. Then there was COVID patient screening for TB. There was another algorithm. Besides, there was an algorithm where a person who's having ILI or SARI was screened for tuberculosis. These were the protocols which were in place, were used to augment each other in diagnosis and evaluating and treating as per the protocols. So all these patients, who were diagnostic as TB were also being screened for COVID-19. As you can see, amongst the notified patients, we notified roughly about 15.8 lakh patients of TB in this period till November, and roughly 19% have been screened for COVID. And we are able to detect for COVID in about 1.1%, that is 3,300 patients. And this has, as you can see, has progressed over time, and the number of patients who are screened, TB patients who are screened for COVID is also going up gradually. So what is the implementation and TB, what screening, what the best practices we saw? That the chest X-ray was done for all ILA and SARI patients. In Delhi, about half the TB technicians we were using them for COVID work, and the remaining half, which we had working for us, were alternating duties between different designated microscopy centers or in their own centers and adjacent facilities. Him Suraksha was a campaign which was started in Himachal Pradesh, where they did door-to-door screening for TB as well as COVID. And in Lakshadweep, they used the TrueNet diagnostics in all the islands. But there were some major challenges. One was the stigma, then the fear of contracting illness by the health workers were the commonest reasons which were cited by states for not implementing bidirectional screening. So people were not moving, to contacting the patients when at their houses also. There was a difficulty in sputum collection and transportation due to lockdown. there was a lack of BSL-3 lab facilities for testing. These were some issues which were there because initially all the TrueNAT, the CVNAT which was done we were not very sure whether we are dealing CVNAT with a patient who had COVID or it could be tuberculosis. So we need BSL-3 facilities there, and which was, we tried to, co-located ones were used for helping this out. There was a poor documentation, there was a lack of clarity, how we record and report these, both the twin pathologies, and getting ILI-SARI data from the health system was also difficult. So these were the issues which was faced by the program. Now that the pandemic is on the low side, we're having much less cases. The screening for TB has improved. Some of the lab techniques are back in place, and we hope that the TB program will back in the way it was prior to the COVID, and the challenges what we have faced for reaching our goal of 25 can be now taken care of in because of that the pandemic is on a low, and with this I think I'll end the talk and will hand it over to, I think, Dr. Vinita. Thank you so much.
Thank you so much, sir, for enlightening us and making us actually aware how badly this pandemic has affected our TB services. But, sir, because this is a deadly syndemic, questions never seem to stop popping up in our minds. So I'll just hurriedly take you through some of the very important questions that keep on crossing our mind, and we can just very hurriedly see if we can answer these questions, sir. So can you see the slide, sir? Okay.
You say, is the TB COVID co-infection more severe? Yes, it can be more severe. It may be more severe, and it depends on how severely is the lung involved. If already the lung is diseased, and it does have a high mortality, which you have already pointed out. I think in your first slide you showed there was a high mortality, and the severity of infection was more.
Okay, sir. Does a coexisting TB-COVID infection pose a challenge to the differential diagnosis? I'm sure it does, sir. But
it certainly does. It certainly does. And there were the challenges. The challenge is not only in the diagnostic, the challenges were even taking up for testing also. Some of the people, the lab technicians were not ready to test the sputum at initial phase, but it is a challenge. And even the radiological challenges can also be there at times.
Okay, sir. So how does this pandemic impact the latent TB sequelae or TB treatment? What I mean to say is, can an infection of TB reactivate to TB disease?
Yes, it is possible. It can be. I think we need to look into it. But considering that India has roughly half of a population which has latent TB, it's a scary situation. But yes, a pandemic can infect latent TB. It can progress into TB.
So do we have any data? Do we have any?
No, we don't. No, we don't have. No, we don't have any data as yet.
About the latent infection reactivating into disease?
No, we don't have. No. Okay. Very difficult to have this data.
All right. Yes, sir. Sure. Do we have any guidelines recommending what a patient on TB treatment who is already on treatment should do when he gets infected with COVID-19?
We follow the same guidelines. We have to just ensure that the patients who have been on treatment with TB continue with treatment. There's no interruptions, or wherever interruptions are required at the minimal level, so that they are able to be back on treatment and complete the treatment and get cured.
And sir, it would also depend on the stage at which both these infections are being diagnosed.
Exactly. So it has to be managed accordingly. Yes.
Right.
We need to interrupt the therapy. We might need to alter the therapy depending on how sick the patient is.
So, but maybe is there any guideline in place which covers?
No. These are all clinical managements which will be based on real time. The way they are. Maybe you require injectables when the patient cannot take orally. So everything depends on individual situation.
Okay, sir. So a person who has recovered from TB, is he at a greater risk of COVID-19 infection?
Yeah, they have some data to point towards this direction. Yes.
Yes. Okay. And the very hot question: does BCG vaccination prevent against COVID-19? Do we answer?
Yes, it is shown that, but however, we need to see how fast the protection comes. Even if the BCG is given, We need to how fast, whether we need to give it right away, we give it right away and we have the protection within 2 months. So this,
could you apprise us of,
we really need a study on this.
but could you apprise of the us of the little data, if at all there's any data available on this BCG vaccination and COVID-19?
It's basically based on countries where you have universal immunization program. You see that less number of patients are there of COVID-19, so it could have protective value. But how rapidly the protected value comes is very difficult to say. Now, if there's a pandemic on, do we give a BCG and see how fast we get it, the response? So their studies are ongoing. Let's see what the final data comes out. But at this time, I think the vaccination remains what are vaccinations which have been approved by WHO.
So especially in pediatric age group, has there been any study relating the COVID-19 in pediatric age group with BCG vaccination coverage?
No, I'm not aware of any as such. But if you are, you can always tell. I don't think so.
Yes, okay. I think you've already elaborated a lot about the program, what it is doing to lessen the impact of this pandemic. So finally, that's all from my side. And sir, you would like to add anything further? Any parting note?
Thank you so much.
We really thank you so much, sir, for giving your time here. And Dr.
Can I say?
Yes, sir.
Can I say 2 words? Thank you, Dr. Shoni Khanna, for your lucid presentation. Actually, like for TB, you are in and out. You have from A to Z, you are expert of TB basically. So I was worried about this scenario only that during COVID period, because of the lockdown, patients were not being, they were not coming for reporting. But how do you expect the post-COVID challenge? Because, or how do you expect the post-COVID challenge?
See, what has happened is, when we see the notification, the private sector, we have 1/3 of the notification private sector and 2/3 from our government sector. What we saw during the pandemic, as of when it was going on, there was a severe fall in private notification because the private sector has closed down, but the public sector was, you were having about 80% of the private sector is functioning. As of today, what has happened is the private sector is back. We are having over 100% notification, which is expected at this given time. And even the public sector, which was from, at 80%, at least in Delhi, has really reached 90%. So the challenge may be now that everything has opened up, we should be able to, we will not be able to meet our targets for 2020, what we were expecting to find, roughly about 27 lakh patients. But we will have about downfall of about 10%, maybe 10 to 15% of what we needed to find out when we are moving towards our goal of TB elimination. So there is a setback, but I think with time, if things remain good, we'll be able to catch up.
Okay, Dr. Nadeem, do we have, since sir might be leaving, I'm not sure. So could you just see if we have any relevant question on this subject?
Thank you, sir, for a very deep insight into the topic. I think most of our queries regarding the COVID-19 and TB co-infections and the challenges associated with them have been addressed during the session. However, there is one question which I can see, sir. The question is, can somebody who is having active tuberculosis infection or is under treatment take this COVID vaccine?
I mean, I see no reason why not. There is no guideline on this. Everything is silent on this. And as a matter of fact, I got this question from somebody in Rajasthan also. Yes. So I see no reason why they should not get it. Exactly. The question.
Okay.
There is no guideline on this. Yes, it's silent on this.
Okay. Okay.
One question I have to use directly. Will this TrueNAT be diverted back to TB, sir?
I think we can talk about this TB, but if you're doing your TB one, so carry on. We'll let you have it.
Are we allowed to do that, sir? Are we allowed to do that because it belongs to you? So I'm just confirming.
No, you can use it for TB.
We can. Okay, sir.
You can.
Okay, thank you.
Okay, we'll let you have it. You can keep it, but use it for TB. Yes.
Please don't take it back, sir. That's just what I want to say.
So many people have heard, so I can't say no after that.
Okay, thank you so much, sir. And we are really privileged to have you here. And I mean, what else can I say? You are the person who is.
Thanks a lot. Thanks a lot.
Thank you so much. Thank you.
Okay.
Over to you, Dr. Nadeem.
Thank you. I will now ask my colleague, Dr. Manoj, to take us through to the last session of this workshop. Dr. Manoj, I request you to share your screen.
Hello, I'm audible.
Yeah, you are audible.
Hello.
Yeah, you are audible.
Hello. Okay. Hello. Good afternoon, everyone. Dr. Nosh, Officer, Department of Microbiology, UCMS and GTB Hospital. Now we move on to the that is topic of last session is viral and bacterial infection. After the enteric and parasitology lab, her area of interest is enteric infections by Microsporidia. She has more than 90 publications in reputed national and international journals and has edited many books and contributed several chapters in many books. She is the associate editor of Journal of Gastrointestinal Infections. Our expert speaker is Dr. Debashish Dhar.
Hello.
Hello.
Yeah.
Hello.
Yeah.
You're audible.
Yeah. Am I audible? Hello.
So, yes, sir. Sir, Dr. Debashish Shah is senior consultant, Department of Critical Care Medicine, Sir Gangaram Hospital. Dr. Debashish Dhar's area of interest is sepsis management, non-invasive and invasive ventilations, and hemodynamic monitoring. He is past present ISCCM Delhi branch, and he has national and international faculty in critical care conferences, teachers in DNB and ISCCM curriculum, has numerous publications in reputed national and international journals. Now I hand it over to Dr. Rumpa ma'am. Ma'am, Rumpa ma'am, please admit yourself.
Rumpa ma'am.
Rumpa ma'am, please admit yourself.
Rumpa ma'am, please unmute yourself.
Hello.
Rumpa ma'am, yes, you are audible now, ma'am.
Now we move on to the portion of the viral infections and bacterial infections. And is it at all important to know regarding this co-infections in COVID? So, okay. So, in fact, earlier we had received instructions were received from CDC and WHO that testing for fever and in cases with fever and lower respiratory tract infection, we should test only for other viruses. For example, if we get instructions for if we get infections like influenza, it was specifically mentioned that we should not be testing for SARS-CoV-2. Okay, but subsequently, reports indicate that co-infections may be an important reason for delayed diagnosis of COVID-19. And more recently, experts have also recommended that individuals who undergo testing for SARS-CoV-2 should additionally be tested for other common respiratory pathogens besides influenza. And information about the type and rate of respiratory infection. Other respiratory infections, for example, in seasonal pandemic influenza, MERS or SARS, may show differing levels of bacterial co-infection. In fact, it has been suggested that bacterial infection results in overall may account for up to 30% of community-acquired pneumonia cases in cases of influenza. Whereas there is evidence that co-infections may not occur in patients infected with MERS and may occur rarely in patients infected with SARS-CoV-1. Furthermore, co-infections have been associated with, it has been seen that co-infections have been associated with more severe outcomes in pandemic and seasonal influenza. So the information about the type and the rate of respiratory co-infections has potential diagnostic and treatment implications in COVID-19. And it is also possible that treatment of a particular viral infection with antivirals or atypical bacteria with antibiotics might improve the outcome of patients with COVID, co-infected with COVID-19. Alternately, individuals with co-infections may not respond to treatment in a manner which is similar to those with without COVID-19. And so, mainly for these reasons, the knowledge and the prevalence and the type of respiratory co-infections has important management and outcome implications in COVID-19 patients. So, with this brief introduction as to why we should know about the different viral and bacterial infections in COVID-19, I would request our guest, Dr. Devashish. Dr. Devashish Dhar is working in the ICU to show us some interesting cases that he may have come across during his time. Dr. Devashish, please.
Yes. Hello. Am I audible? Hello.
Yes, you're audible, but we can't see you, sir.
No.
You're not
Sir, you're
visible.
audible. Please switch on your
I'm not visible.
video.
Okay. Sorry.
You have been instructed to, sir, start your video. It's
Sorry. Yes. Hello.
Yes, sir, you are visible.
I am visible, but okay. No.
Yes, you're visible and audible both. Please start sharing yours.
But I'm just trying to find.
So there must be a green button, the share screen button. Yes.
Share screen, yeah. There is a green button, yes. Just a minute. See, what I'm just trying to find. I mailed it to Dr. Rumpal, so that way. Just I'll try to share some experiences. See, the point is that, I mean, just wait. Is okay now? Hello? Hello?
Yes, sir, you're audible, sir.
Is it audible? Okay, fine. So, I'll see the most important thing that I'm working in the ISO setup, and whatever I'll speak, it is from that point of view, the ISO point of view, and what challenges that we faced with the co-infections during the ISO patients. In our experience, when we did this, we saw these patients in the ICU. As you can see, the majority of the patients who are there in the, just a minute, I see this. Is it visible now? Hello?
Yes, sir, the slides are visible.
Slides are
Ma'am has
visible,
started sharing this.
Yes.
Yeah.
Slides are visible, fine. So what I want to say is that the COVID infection, as everything has been discussed till now. So among the ICU patients that you see, we have got not more than 1 or 2% of these patients ultimately landed in the ICU in our experience. And we have treated around 850 patients of severe COVID in our ICU till around 31st of December. Out of which at least we have not got the estimated all the data, but around 500 patients, more than that, we have ventilated them. So what we found that the co-infections are there, but they are during the hospital admission at the time of that they develop as a hospital acquired also. And majority of these patients who are there in our ICUs compared to the non-COVID ICUs, we have found much longer stay in these patients. They are much more critically ill, and incidences of your comparatively infections or the second infections, that is hospital acquired infections, were much higher in these patients. The first case which I want to share is one patient who came to us from Punjab. Now this patient, and all these patients, as you know, they have a comorbidities, a diabetes, a post-CVG, he has a chronic kidney disease, but maintained on medicines. He developed COVID in month of September. He was treated himself in the Punjab, Bhatinda, he came from there. And that time gradually improved, and he got discharged on 30th of September from this first episode of the COVID. He was discharged home. At that time, his condition, though he was stable, but still he was on oxygen. But he was maintained on oxygen and steroids and the anticoagulants at home, and with that he was continuing, and gradually he was improving. But the first week of January, he started suddenly having altered sensorium, fever, and that is the time they got alarmed and they decided to come to our ICU. So when he came to us, we found that he was maintaining oxygen saturation of around 90-95% with 5 liter oxygen. His oxygen requirement has gone up, but otherwise he is stable, but he is definitely febrile with temperature more than 103. He has altered sensorium, he is dull, but he has responded to verbal comments. His investigations, what we do, they are unremarkable. And we did the COVID antibody, that was positive, but RT-PCR this time was negative. But because of altered sensorium, we did a LP and the CSA was examined. And the CSA examination revealed 20 cells, which are all lymphocytes, proteins were significantly high, glucose was normal. And when you tested the CSA for that, it shows your herpes simplex virus was positive, PCR. So the patient was then put on injection in cyclovir and other supportive cares, and right now he is improving, still in our ICU, and he is recuperating. So this is one co-infection of the we have seen. Similarly, we have seen CMV infection, at least 3-4 patients. Now out of these 2 patients who have got, suddenly they were bloody diarrhea, these patients. We did a colonoscopy. Colonoscopy showed rectal ulcers. And from that ulcer, the biopsy was taken, that showed CMV was positive. So these are the 3 infections of in the ICU that you have seen: CMV, 2 CMV infections, 1 herpes simplex as a co-infection, the viral co-infections. The other case, which is a patient who come to us, he is a known case of chronic kidney disease. He is on regular dialysis with a permacath, that is the catheter, the dialysis catheter, which was already on him. He presented to our casualty with a suddenly onset of breathlessness, respiratory rate, high respiratory rate, or saturation, which is around 74%, and he is in severe breathless. He was put on oxygen, high flow, despite that his saturation was not improving, he was in 84. But this patient I'm talking about, this is somewhere presented to us in the month of June. And that time I can only assure you that this type of patients who are having this chronic kidney disease, other thing, they are neglected like anything. Because none of the hospitals are doing proper dialysis. These people, because of the lockdown, they have non-availability of all the, this transport, other things. They are not doing regular dialysis. Actually, he has missed 2 of his dialysis. His ABG shows severe acidosis that time with the potassium was 6.5. As per the rule, any patient coming with breathlessness and fever, we are doing RT-PCR. His RT-PCR COVID-19 was negative, was positive that as soon as he came to us. The patient was put on, then immediately ventilator, dialysis, and everything was done. We did the investigations. Investigations were shown definitely the KFTs were hayway. The TLC was 28,000.
Excuse me, sir.
Yes.
Excuse me, Dr.
Yes.
Devashish.
Yes.
I think your screen is not visible. Could you try once again?
It's not visible. You said it was visible that time?
Are you able to see the screen?
Where I
Screen
can
is
see that.
visible.
Are you able to see this?
Yes,
Screen
I can
is
see.
visible.
Yes.
Okay.
Screen is
sorry.
visible, but the slides are not advancing.
Slides are,
Yes.
Slides are not advancing.
yes, ma'am, we are
slides are not
still continued on the case.
No, it's not.
Hello.
Hello.
Yeah, the
Sir,
slides are not
I'm sharing
advancing.
again after. Sir, I'm sharing again. Are you on this slide, sir? Is it visible?
This slide.
Yes, ma'am, the slide is visible.
Yes,
ma'am,
slide is visible now. Okay,
Yes.
fine.
Dr. Rumpa,
Yes, sir.
slides are visible, but as you are pointing at slide, we are seeing slide number 3, but you are discussing slide number 6.
Oh, why is it so?
So slides are not moving actually. और
It's stuck on
slide
case
share
one.
पूरा screen पे नहीं आ रहा है.
Sir, can you share, Dr. Devashish? I'll stop sharing then. I don't know why this is happening.
Computer की problem.
He can say.
It
na,
would be
these
easier
slides.
if
He can
Devashish.
say. He can say.
Dr. Devashish, would you like to share? I can stop sharing then.
Hello.
Hello.
Yeah, sir, would you share, sir?
Yes.
Dr. Devashish, sir, would you share the screen? Because I don't know,
Yes.
somehow
Yes.
I was.
It is there in the screen.
Yes, sir, it's actually not, the slides are lagging behind.
It's okay
Now
now.
slides are
Moving,
not
sir.
visible.
Slides are visible, no? Yeah.
आप लोग को चाय पानी पी लो कैसा रहा हमें भी पिला दो हम हो गया मैं क्यों पिलाओगे क्यों नहीं पिला सकते
Is it visible? No, you can have tea after some time. Don't worry.
Devashish, sir, your slide share has not started. Your screen is visible, but the slides are not being shared.
Yes.
Yeah, yeah.
now it's
Now it is coming. Full
Share.
screen
Now-
preview, sir, it's coming.
Is it now available? Can you
Yes,
see
sir,
it?
it's visible,
Yes,
sir.
sir.
You're on case number 2.
Yeah. So as we are discussing this case, so am I audible also, I suppose?
Yes, you're
Yeah.
audible.
Okay. So this is a patient which I'm describing. This is the month of June. He came to us. As I was telling, that time the lockdown was at its at the beginning, and none of the things were as such in place because it took time for everything to settle. So these type of patients who are on dialysis and all those things, they are in real sufferers actually. These patients, they are missing their dialysis. So he came to us, he missed 2 dialysis. He came with severe breathlessness in our casualty with a severe with a hypoxemia with an oxygen saturation 74%. And AVG shows a potassium of more than 6.5 and a mixed acidosis. So as he was febrile also. His RT-PCR turned out to be positive, and immediately all the supportive measures, dialysis and all those things were done. His investigation we did that shows a TLC of more than 28,000. Inflammatory markers, they were raised. As he has not undergone dialysis, the kidney function also was deranged. His macrobiology we sent because of fever and he is having the catheter in situ, we sent the cultures. The blood culture shows Pseudomonas aeruginosa after 48 hours. He was treated with the appropriate antibiotics, supportive cares, and that he improved, and his oxygen saturation and everything improved. And by 5th day, he was elevated and he was fine, and he was off oxygen. And he was maintained on room air since after 8 days. But when we repeated the COVID RT-PCR, it was again positive on the 10th day of admission, again repeatedly on the 15th day of admission also it was positive. So patient then discharged on 21st day after with appropriate advice. So these are 2 interesting cases which I want to share. So what it shows, why I shared these 2 cases, I just want to tell you that See this patient, which is second case, the RT-PCR for the COVID, it remained positive, despite the patient become absolutely fine. And though he came with breathlessness, he never behaved like a patient of COVID pneumonia. He was more of a patient of primary infection, which has been acquired in all these patients of CKD that we saw. And we have seen such a lot of this type of patients who are chronically sick, who had come to us, and RT-PCR has been incidentally turned out to be positive. And they have been labeled as COVID, and even if they have died, they have put them into under the COVID account that they have died with the COVID positive. Now, these are the challenges which are of your COVID pandemic, the co-infection, as far as the viral and the bacterial. The major bacterial things that we have seen in these patients are this thing, Pseudomonas, and the second we have seen Acinetobacter and the Klebsiella. Though my topic doesn't count fungal, among the fungal we have seen there is increased incidence of Candida auris in my patients. There is increased incidence. The majority of the patients who are growing the fungal, they have got the Candida auris, which is not there earlier in our main ICU. In the COVID ICU, there is increased incidence of that. So these are the things which are there, and the major reasons which we attribute to it definitely is the fact that there has been a compromise in the hospital infection control and the infection control of because the number of patients are more. We have made suddenly ICU has been made, trained staffs we are lacking. So 1:2 up to, you have to go on even up to 1:3, 1:4 staff sometime from the nursing. So all those things must have added to this. So these are the issues for which I think the co-infection needs to be addressed, and accordingly the proper treatment can be planned for this patient. With this, I hand over the screen to Madam Rumpa for further elaboration of the topic and the further discussion. Thank you.
Thank you, Dr. Devashish. Definitely very interesting cases. You had got heartbeat, you have got CMV, and you have also got Pseudomonas, Klebsiella, you've got Acinetobacter, and you have got Candida auris also. So, the challenges that you faced in diagnosing these infections and treating the patients, definitely. Could you just tell us as regards to what is the prevalence and the type of common co-infections with respiratory viruses and bacteria in these individuals who are SARS-CoV-2 positive, the common ones?
See, the patients when they came actually, for that in our hospital policy used to do a rapid biofire and those things. So this time we have not done such things, to be very frank. But definitely some of these patients, H1N1 we have found in a lot of a few patients. Then influenza A, influenza B, that also we have found. So these are these three viruses as a co-infection respiratory viruses we have seen. And as far as bacterial, as I said, it was mainly the Pseudomonas. Strep pneumonia we have not found, at least in our culture that we have seen in the ICU. We have not seen any patient with the your strep pneumonia, other thing like coming. But definitely, as I said, the Pseudomonas, Klebsiella, and these, they are more common. We have seen them. But from the community which is coming, strep pneumonia, I have not seen a single patient in my ICU subpopulation. But this is what I am talking over the ICU cross section. Maybe in the ward patient may be there. I have no idea. I can't share it. But maybe the microbiologist would be a better person to share it that time.
Sir, did you get any atypical bacterial infections? I mean, in your side, or is it common?
Like mycoplasma or this kind of thing. No. See, that is why I say, and one thing I have to share here is that anyway, we are giving this patient as part of the routine, the azithral, and this was given to all of these patients. And a lot of these patients, they already taken azithral because this was become a style that you are giving azithral, doxy in the OPD basis to all these patients as soon as they are giving a fever and upper respiratory tract infection. And this becomes initially the part of the treatment recommendation also. So it could be that by the time they came to us, so we could not grow any of these things. That could be a possibility.
Yes, yes. It is also possible that you said that patients with suspected secondary infection may not have had the chance for thorough microbiological investigations, given that
Yes,
the unprecedented
definitely.
circumstances and the enormous strain on the hospital system. And moreover, also many studies have also shown that COVID-19 patients, in COVID-19 patients, the empiric use of antibiotics in majority of them. So as you have said that this could have decreased the sensitivity of the bacterial cultures,
Yes.
and this could have resulted in underestimation of the true numbers of co-infections.
Yes.
Am I right, sir?
Yes, absolutely.
So, sir, what is the implication? What implication does the concurrent bacterial and viral co-infections have on the mortality of the patient? So, can we draw a conclusion as to whether patients who have concurrent bacterial or viral infections will have a worse prognosis than those in whom SARS-CoV-2 is the
I
only
think
detected pathogen?
no, I think it should be rather the other way around. The patients who are more critically sick, they got more of the secondary infections. See, the secondary infections and the co-infections which are occurring, per se, it is very, I mean, if you say whether the pneumonia, if you talk of bacterial pneumonia, it is a very typical thing. It is a lower pneumonia. When you talk of viral, it is interstitial pneumonia. It's very unlikely that viral pneumonia and bacterial pneumonia both are present, and you can't distinguish between the two. But the presentation wise, if you go this clinically, patients who has a co-infections, definitely they are much more sicker, and they have a higher mortality. Yes, definitely so. But this higher mortality and the co-infection, is it because they are sick, that is why they got more co-infections, or it is because of COVID-19 which has make them more predisposing to prerequisite as a for that co-infection? That is very difficult to say. That is not I mean, we can't conclude like that. Does they do go hand in hand and that kind of thing? But definitely there is incidence of co-infections more. But that co-infections, patient who have co-infections, they have higher mortality. Yes, that is true in the ICU setup. Yes, that I agree.
Right, sir. Sir, as a clinician, do you think you can distinguish co-infection from SARS-CoV-2 infection? Or, I mean, what diagnostic modalities should be adopted for detection of these
See, from the
viral
viral,
infections,
yes,
especially viral I'm talking about?
viral point of view, it actually doesn't matter much. Let me be very frank. When you talk of viral pneumonia, it is a very specific subgroup. And there, whether you are having lot of this diagnostic thing modality, hello? Yes? This diagnostic modality is whatever you have got. Even if you have got this diagnosis, there is no specific treatment for such as such. I mean, there is no way we can prove that by giving antivirals, the patient's course of disease has changed. Even if the remdesivir, which has been used for this COVID-19, it has no, unlike your antibiotics for antibacterials, where definitely you have, so we can say the patient become culture negative and this, but still remdesivir, other things, we have not shown that. Patients who are having, because we have no such definitive way to say the viral has cleared just by giving your antivirals. There is still no such thing. So whether viral co-infections from the clinician point of view is very important to know, I really don't know. What we have to give anyway in this patient is a good supportive care. So even if he has got 5 viruses, like he has got coronavirus, along with that he has got arenavirus, he has rhinovirus. How does that, I mean, the treatment from the ICU point of view, from the supportive care, doesn't change much. So that I think is, but from the bacterial point, yes, definitely we have armamentary or different antibiotics. So there we have to select with the GNV, GPC, what type of resistant patterns, MDR, XDR. So there it is a difference, but not in these patients, I suppose.
Yes, definitely. The whole set of antibiotics coverage will be different in case of bacterial. We don't have much to give them in case of viral. That's absolutely true. There is evidence that these inflammatory serological markers that are usually associated with bacterial infection, such as procal or CRP, they appear in patients they may appear in patients with COVID-19 without a corresponding bacterial co-infection occurring. There is evidence of such markers present. So what is your take on this, sir?
You see, the point is that a lot of, sensitization has been done with this COVID-19 pandemic regarding the inflammatory markers and then cytotoxic storm and all those things. But if you see that any patient, when you have any acute infections and such things, all these markers anyway going to rise. These are the human, your response, the stress response. It is the response to that. And it has been shown that even the septic patient also this rises. IL-6 and those things. Even these patients who have, there are lots of studies which come later to prove that not only the COVID-19, there's much increase in the ferritin level in the patient who have been, undergone septic shock. So this, it is a part of the host response. The host response to any patient, anytime having these conditions, so they will have a host response. And the host response will be manifested by increase in the IL-6, IL-10, increase in the iod, TNF alpha, any other cytokines you talk of, they will be all increased. So that is how it has been manifested. And so you have secondary HLH, which has been said is a part of the host response. So this only shows the severity of the illness. The severity is more, and that is why they have behaved in this way. And that is how we should take it. And as such, till now, none of the diseases, the drugs which have initially suggested, like tocilizumab and that to counter this cytotoxic storm, has shown any improvement in the outcome. Though some late studies which has come, like REMAP-SCAP study, where single study, some studies, they have come out with some ideas that, okay, they have got, this will improve. But per se, no improvement as such in the outcome has been there. And the other thing which I want to say is that we have used some patients tocilizumab and that all these patients ultimately land in a severe secondary sepsis. So initial crisis, the 5-7 days we might have tied over, but after that they all land in a severe secondary sepsis and the shock. So we have a very bad experience as far as tocilizumab we have concerned that we have used in whatever patient we have used.
Right.
Hello.
Thank you so much, sir, for sharing your vast experience and the very interesting cases that you have shared with us. We are very much grateful to you for sharing with us your experience.
I'm thankful for you got the invitation from you. Yes.
Hello, sir. Sir, hello, sir. There are some questions from audience.
Just a minute, sir. Just a minute. I would just like to summarize what the sir said, and then we'll start with the questions. So, can you just stop sharing your screen, sir, Dr. Dhar?
Yes.
Yeah, thank you, sir. Before we come to the question answer session, I will just share the. I will just summarize.
Manoj is not asking anything.
Can we do some? Can
Sir,
we take some questions? Still, Rumpa, you are ready with the slide?
Just
Acha, you are ready.
can we? Can you see the? Yeah, yeah. I was just. Yeah, the viral infections. The most important, I mean, the most prevalent of the viral co-infections in COVID-19, up to 16%, is with respiratory syncytial virus, which is followed by 15% rhino, parainfluenza, adeno, metapneumovirus, Coxsackie virus, bacterial infections also. We have the most frequently detected bacteria. The literature says are Mycoplasma pneumoniae, 42%, which is followed by the common bacterial infections like Pseudomonas, then Haemophilus in 12% each, and this is followed by Klebsiella pneumoniae, which in most cases are carbapenem resistant and also ESBL producing. And actually, in studies where the diagnostic method was described, all the Mycoplasma pneumoniae co-infections were diagnosed serologically through detection of IgM. This on its own is not highly specific test and may result in an overestimation of the infection. That is there. So, and probably given the chance that most cases were not thoroughly investigated for the atypical bacteria, the number of cases of Mycoplasma pneumoniae may not have been truly estimated. And the other bacteria which were detected are Enterobacter, Acinetobacter, then Serratia, in some cases MRSA, Enterococcus faecium, 14% in studies that included only ICU patients. And atypical organisms detected and as I've already mentioned, that a minor percentage of the patients appear to have been investigated for atypical organisms, and this will reflect cases of this pandemic suggested that bacterial co-infections are less prevalent in COVID-19 patients as compared to earlier influenza A pandemic of 2009, and the patients who do not have co-infection from SARS-CoV-2 infection. And by contrast, the clinicians also cannot rule out SARS-CoV-2 by ruling in other respiratory pathogens through the old syndromic multiplex panels at this stage. If newly developed syndromic multiplex panels that incorporate SARS-CoV-2 may facilitate earlier detection of co-infection. However, as Dr. Dhar has already said, in case of viral, there is even if we detect, there is not much to offer, except in cases of bacterial, where we do have our armamentarium to take care. So therefore, the clinicians must have a high index of suspicion for co-infection among COVID-19 patients, and clinicians can neither rule out other co-infections caused by respiratory pathogens by diagnosing SARS-CoV-2 and nor rule in COVID-19. So the testing for co-infecting pathogens during the course of a pandemic is important. It is possible that patients with suspected secondary infections may have had a thorough microbiological investigation, given the unprecedented enormous load on the hospital system. Further, it has already been emphasized that there's been widespread use of broad-spectrum antibacterials, despite there may be a positive evidence for bacterial co-infection, and in most cases, no antimicrobial stewardship probably have been described in many of the studies where high use of broad-spectrum antibacterials have been done. So empirical administration of broad-spectrum antibiotics may also decrease the sensitivity of bacterial culture methods and lead to an underestimation of the true number of co-infections. So this is to summarize what we have discussed just now. And I feel that Dr. Manoj, if you can get on to some of the questions you were telling, any address to Dr. Dhar? Dr. Manoj?
I'm
Yes,
audible?
there were some
Hello?
queries.
Yeah, there
Audible?
are a number of questions for Dr. Dhar. Dr. Chavi wants to know, what is your opinion on empirical broad spectrum antibiotic considering viral sepsis, which is a distinct entity now?
So
Dr. Dhar, can you hear me?
unmute
Please
yourself.
unmute yourself.
Dr. Chavi, you have to unmute yourself.
Please
Yes.
unmute yourself.
Yes. Hello.
Yes.
Hello.
Yeah, now we can hear you.
Yes. The question is that whether the way why the and antibiotics being given to them. That is what you want to exactly. I missed the question. Can you repeat the question?
What is your opinion on empirical broad spectrum antibiotics considering viral sepsis?
Yeah. No, see, the point is that initially none of these patients, we tried to avoid antibiotic all these patients initially. Maybe for initial 3 days, 4 days. But once suppose his clinical improvement is not there, his fever is not getting corrected, he is a diabetic patient, he is having high risk groups, his oxygen requirement going high. Then as a clinician, it is not possible for me to not to give any further antibiotic anything, because there is, even if your recommendations and everywhere it is written, that if you consider that there is a second infection or that suspicion, the antibiotic needs to be given. It is theoretically or logically, it is easy to say that, okay, don't give an antibiotic to such patient. But if the patient is not improving clinically, initially you may see, we may avoid for 1 or 2 days. And also, as I said, majority of these patients, they are receiving azithromycin or azithromycin as well as your doxycycline initially. So that itself is an broad spectrum antibiotics. With they are covering atypical, they are covering gram positive, they have a good gram negative cover. So all these things they are already receiving. So it is not that they have not received any antibiotics. No. Even if you don't want to give antibiotic as a garbo giving antiviral, they have got all these things. So azithromycin, one of the most used drug, has been used in this pandemic. Same with the doxycycline. And every person who has come to us has already received it. Even at home also they are getting it. So there is no question that we have not given that. They have already received the antibiotics.
Yes, right. So that is covered. So this also answers Dr. Kirti's question. There is another question from Dr. Rohini, who is asking what precautions are to be taken for handling COVID sputum or blood samples. Is there any precaution we would suggest?
See,
Dr. Gagandeep can answer that. Or maybe Sir wants to answer this. Sir, Dr. Devashish.
Yes. Gandhi, tell me if you want to answer it.
No, I thought it was a laboratory based. Sir, you can answer.
See, the point is that exactly what precaution are taken at the laboratory level, I can't say, but from the transport level and from the collection level. So that is what our part, what we are doing as this. So the usual all persons who are doing it, they're all in your type 3 PP, along with all the sterile precautions that has been done. With that, the person who has been transporting it, and these are all separate containers we received from the microbiology department for transport of all these sputum and blood collected there, and they have been transported with a route which has been fixed already in the hospital. Not that they have been the person who have been earmarked to transport it, they are also in type 3 PP, and proper route they have given it to a person in the microbiology department. And in the microbiology department, what handling has been done, I can't say. That maybe the laboratory person will better to say.
That is, it is important in case of sputum actually. Sputum, because being a respiratory specimen and that too from a suspected COVID patient, I think sputum samples should be treated in biosafety level 2 And same is for blood. When blood culture bottles, when they are open, they should be opened in biosafety cabinet too. So I think that precaution should be taken while processing these sputum specimens for even for bacterial cultures. And blood specimens, when they are when the conventional bottles they are open, then you can use biosafety level 2. And I just wanted to know that is Dr. Malini Sharif is there?
Madam, what?
Yeah, I'm there.
Hello, Malini ma'am. Do you have any experience of bacterial co-infection in COVID, because your hospital was processing all those specimens? And I know that there are Devashish has done very well about his talk. This thing is that there are two types of patient. One group of patient has been treated at home, which is having COVID positive, and one group of patients which are serious, they are treated in the hospital. So do you have any study or any knowledge or any practical experience that the bacterial etiology was different in all these two cases? Because in community acquired, even Staph aureus may be important at that point of time. Because in secondary infection at home, the patient may land up into the ICU or into the hospital. So do you have that experience of bacterial etiology?
Since we don't have separate COVID beds here in Patel Chest, we have one emergency, one separate room is created. So whenever a patient comes with any of the respiratory infections and which the clinical criteria which he fulfills, then they are put in that particular emergency 2, which we call it. And then they are tested for, RT-PCR is done in these cases. So till then they are kept in that emergency 2, and once the RT-PCR results come, and if they come out to be negative, then they are shifted to ICU or ward, wherever whichever is necessary for them. If they come positive, then they are referred to other COVID hospitals. So generally our cases, we don't really have the COVID positive cases with us. And from samples which we are getting from ICU and other places, then it is regular samples of other COPD and other respiratory diseases patients who get admitted. And that usually we have the Pseudomonas, Klebsiella, Acinetobacter. These are the commonest ones which we. So as it is with COVID positive cases, we don't have much experience. I think it answers your query, Dr. Singh.
Can we look at more? Can we look at more questions?
Actually,
Hello.
Staph aureus is relatively much less common in SARS-CoV-2 as compared to the influenza and other MERS, etc. In this pandemic, SARS-CoV-2, and even Dr. Devashish has already said that during his whole of the time, although they have seen a number of cases. So these are probably less. In fact, a whole burden of bacterial co-infections and even viral co-infections are less.
So,
Dr. Shukla, you can take.
Yeah, can we take a few?
Is there any other question?
Yeah, there are a lot of questions. I think couple of questions from fungal area. We can have those questions from Dr. Kirti. Can you just,
Yes.
Dr. Gagandeep? Yeah.
Yes, sir.
Hello. Hello, sir.
One question from Dr. Kirti.
Wait,
For Dr.
Dr.
Das,
Manoj.
what your opinion?
Dr. Manoj, let me take over the mic.
Yes, ma'am.
Okay. Question for Dr. Gagandeep. Sir, are you audible?
Yeah.
So the question is ICU-4 count necessary?
Can you, I'll just repeat the questions. In the ICUs, do you require these counts, fungal spore counts, what we do as a routine surveillance during the COVID times?
I think during COVID times, it really doesn't make,
Yes,
it doesn't change our practices per se. we in routine, we don't do any spore counts. Only if there is an outbreak or, there is sort of any renovation or a new area is coming up. That is the only time we recommend during spore counts. Otherwise, spore counts can be done in routine, or just to maybe have a baseline of the areas, how, which type of fungi are prevalent in your ICUs or in the OTs. So routinely, ICU spore counts are really, not recommended. There are much more important things related to infection control which should be done, like having proper HEPA filters in place. The air changes should be appropriate. So, the biomedical engineering, they need to really do their job properly, rather than, focusing more on spore counts.
Yeah, just one more question. See, beta-D glucan, most of the laboratories across country do not have. What do you suggest about a galactoman, and what you have, the point of care tests have now come into the market.
Yeah.
But do you suggest that during these COVID periods, we should do it bi-weekly or once a week, at least in all patients, blindly, routinely?
No, they should not be done blindly. Only if, there is some evidence, either clinically the patient is not improving on antibiotics, there are certain changes on CT or X-ray, only then it should be done. What I wanted to make when I mentioned about the point of care test was that because routinely, like we do it twice weekly, so there may be patients who require an urgent galactomannan on a Saturday or a Sunday. So these point of care tests, they have reasonably okay sensitivity and specificity, and they can be done, there and then. So that was my point.
Okay, so that's well taken. And sir has already, Dr. NP Singh sir has said that the biosafety measures, I think that was again another question.
Yes.
So we have to take in the laboratory situation, same biosafety hood, these samples have to be handled in those.
With appropriate PP in appropriate biosafety.
And I think in the bacterial infections, what Rumpa mentioned, there are reports where drug resistance has escalated in Acinetto and in Klebsiella and all this because in certain hospitals, the first line management is Targocid and Levoflox. So like Sir Dr. Devashish said, that we have to be very judicious in the use of antibiotics. So we need to now de-escalate and come back to a normal, just to save the patient, we cannot just rampantly start using antibiotics. So are there any more questions? If not, then sir,
no questions.
Have been answered. So now, so I think I can just request all the speakers and the moderators to switch on their videos so that we can just take a quick click, a photograph. Thank you for this patient listening, Dr. Malini, and there are others also who are on this group. Can please quickly switch on their videos. Yeah, I will just say yes, and the camera, Kirti is taking a photograph. Yeah, so we are all here. No, not yet. Yes, I think we are all here, the speakers and the moderators. Yeah, so Dr. Kirti can take one photograph.
You're blocking Dr. Shukla.
You're blocking.
You can't block.
Okay, anyway, I think that's okay. It's all right. So we can now, sir, can I state the vote of thanks? If anyone wants, the participants or anyone wants to say any words about the workshop, is free to share. Before I just end with the vote of thanks.
Yeah, have you taken the photograph?
Yes, sir. Okay, so I think it was a wonderful experience. It was just the beginning. COVID-19 has
taken the photograph.
Yeah, yes, sir. Yes, sir.
Ma'am, without you being blocked.
Oh, she put a Rama in front of me.
So you have to take another one with you being there. Take a screenshot.
Yeah, so meanwhile, I'll just state the vote of thanks till they get ready with the camera. I think Dr. Ashwini has left. So let me just complete the formality. So COVID-19 has given us a wide scope of learning to apply knowledge and deepen our understanding of this pandemic. It is my privilege to propose a vote of thanks and acknowledge the contribution of those who worked hard for this workshop. On behalf of my institute and and the department, my heartfelt thanks to the virtual Micro Decon 12th Annual Conference IAMM Delhi chapter, who had given us this opportunity to conduct this workshop on diagnostic algorithm for co-infection among COVID-19 patients. We also take great pride in today's workshop, which was successfully conducted as a part of a Golden Jubilee celebration for UCMS. Sincere thanks to Director Professor R.S. Rotella, Medical Director, Professor A.K. Jain, Principal, for encouraging us to go ahead with this workshop, and Dr. N.P. Singh, our Head of Department, for providing encouragement and support. My sincere thanks to all our lovely learned speakers, Dr. Vikas, Dr. Debashish, Dr. Ashwini, Dr. Gagandeep, Dr. Chabi, for accepting our invitation and sparing their valuable time and sharing their knowledge. Equally grateful to our faculty, Dr. Binita, for wonderfully conducting this virtual workshop and the platform, Dr. Rumpa, Charu, Dr. Kirti, Manoj, and Nadeem for coordinating the program. And not the least, I would love to thank all the participants. They were already introduced by Dr. N.P. Singh, Jyoti, Indira, Sneha, Shrestha, Mukesh, Ashna, Lakshmi, Suman, Khushbu, Astha, Dibya, and Suchita. They were wonderful participants from several institutes for registering in this workshop. Hope you all had a fruitful day and enjoyed the proceedings. My thanks to this residents and the senior resident and the junior resident, which are without them we can actually collapse, you know. And so one more word, that the slides, we will be preparing a small manual compiling all the data or the literature that we have taken, that the speakers shared today, and we will be sharing this PDF with the participants very soon. So be assured of that. So with that, I actually just one more photograph. If all of you are there, just quickly switch on the video. Dr. Ashwini has left, I think. So just one minute.
Also,
Ready?
the certificates will be given along with the PDF now. The certificates.
Yeah, the certificates will also be given with the name on the email.
Yes, ma'am. Soft copy of this.
Soft copy will be given.
I think now it is better.
Yeah, this is better now. Done. Thank you so much, everyone. Thank you, everyone. So shall we leave?
Shukla, can I say 2 lines?
Yes, I finished.
Because when we started the proceedings, we were not having the banner of Golden Jubilee celebration. Now you all can see that the banner of Golden Jubilee celebration is just behind me, and that states that University College of Medical Sciences and Guru Tegh Bahadur Hospital, and particularly UCMS 50 years Golden Jubilee year, UCMS 2020-2021 department, because the time was less and we were the first to inaugurate the scientific session or academic session in Golden Jubilee year, and we got this opportunity under the aegis of IMM Microdecon and Golden Jubilee celebration of UCMS, and rest you all know that we had wonderful speakers, wonderful audience, our senior colleagues and our friends and residents, all were they were participating in their capacity. And our residents also, Dr. Seema, Dr. Krishna, Dr. Krishna Sarkar, they did well in controlling the DVMI or the computer programming also. Thank you, Dr. Devashish. Thank you, Dr. Gagandeep. And thank you all. Thank you, Dr. Malini, with us, because you were there with us. Thank you, Dr. Dogra. Your presentation was really excellent. And everybody has did and Dr. Binita, you have conducted this workshop at in our departmental platform, so that we had live streaming also, and this live streaming was seen by many. So people, they have joined from Rishikesh. Dr. Balram joined from Rishikesh. Dr. Sarika from Jodhpur. And there were many people who were from outside, from Delhi. They were, and Dr. Sherwal joined. So I think it was good.
Sir, I'll share the
Overall, it was a
recording as
wonderful
soon as
experience.
possible. I'll share the recording
Yes?
of the thing as soon as possible. As I will share the recording, sir, as soon as possible of the
yes,
whole
yes.
thing for people who could not attend.
Yes. Thank you all.
Thank you, sir.
Thank you
So
so
Dr.
much.
Vinita, I think you can conclude it.
Nothing to conclude it. So I'm so happy. Everybody was so nice, and I'm really thankful to all the speakers and all the guests and all the delegates. And thank you, sir. Thank you, ma'am, for all the support
So
that you keep on
congratulations to the
giving.
Department of Microbiology UCMS for taking the lead at at the Golden Jubilee celebration. Can we leave?
Yes, sir.
Yes.
Dr. Rohini was there.
खत्म।